Good morning. For those of you waiting for the live stream to start, we will be starting at approximately 9:15. Thank you. Good morning. Thank you so much for electing to come here to our national headquarters today for Medicare and Medicaid services. We have an outstanding program for you today, and we think you'll enjoy every moment. I'm Pamela Gentry, the Senior Advisor for the Office of Minority Health. I have a few housekeeping announcements I'd like to share with you before we get started. As you enter the auditorium, you pass the bathrooms closest to this gathering place. We ask that you stay within the registration, vendor, and auditorium areas during the conference. Emergency exits are right through these doors, and then you'll see glass doors which you can entrance onto the terrace of the building. We're asked to gather at area 4. The parking lot areas are numbered, so if there is an emergency, we'd like you all to congregate in area 4. When we break for lunch, we will have staff on hand to direct you to the cafeteria and to the area where pre-lunch orders can be picked up. Both locations will be at the back of the main lobby and down to the lower level. We'd like to request that all cell phones be placed on silent or vibrate, and you will refrain from taking calls during the presentations. We do, however, encourage you to tweet throughout the day. Today's presentations are being evaluated for CMEs and CEUs. Please check out our website for the details, and make sure that you signed in at the front desk next to your name. The number of credits will be determined by the Medicare Learning Network following the day's conference. As the presentations go throughout the day, questions and answers will follow the panel discussions. Because of this, we'd like everyone to observe the time breaks and to return to the presentations promptly after designated rest times. Once again, thank you for joining us. It's my pleasure to turn it over now to our Director of the Center for Medicaid and Medicare Services, Office of Minority Health, Dr. Kara James, who will bring you our official welcome. Dr. James.
Good morning, and thank you, Pamela, for that introduction. And thank all of you for joining us here in person and those of you who are live streaming with us today. We're very excited about the day that we have ahead of us as we take a moment to build on our past and help to shape our future with our lessons learned. And as we think about where we are and where we're going, the journey of 1,000 miles begins with a single step. And I love this quote because I think it really embodies a lot of the work that has happened, as well as where we continue to go in this very exciting time of changes within our healthcare system. And as we particularly think about and focus on today's topic of how the healthcare system is meeting the needs to help us achieve health equity for minority and other underserved populations. And as we just pause for a moment, that first step in health equity and healthcare really just started with something that one may not think of as healthcare associated. And that's the Civil Rights Act of 1964. And the reason that this is really important and critical for helping us on that first step to achieve health equity is because when Medicare and Medicaid were passed a year later, it was because of our predecessors in the Health and Education and Welfare, now precursors Office of Civil Rights, that we have health equity in Medicare as we do thus far. Because they used the Title VI of the Civil Rights Act to ensure that hospitals were desegregated, that the providers who worked in those hospitals also were integrated, and that the workforce in those hospitals was diverse. And had it not been for them, the gains that we saw over the past 50 years for Medicare and Medicaid minority beneficiaries would not likely have been achieved. And we thank them for the 700 employees who went and physically inspected every single hospital to ensure that they were integrated and ready to participate in Medicare and Medicaid when it was implemented a year later. We also are going to reflect today on the report of the Secretary's Task Force for Black and White Health, also known as the Heckler Report, which really was the first federal report to document health disparities and became a stepping stone to really shed light on the challenges that minority communities face. And we think about how our programs and our beneficiaries have evolved in the 30 years since. We look at the implementation of the Children's Health Insurance Program and what that has meant to ensure that minority children are growing up to healthy adults and able to achieve and succeed in society. And then we look at the Minority Health and Disparities Research and Education Act, our first legislation really to focus on minority health and the changes that came as a result of that. The Medicare Modernization Act, also known as Part D. The Affordable Care Act, which is one of the reasons that we're here today, and the changes that have happened. And the timeline continues. Today, we're going to talk about our CMS equity plan for improving quality in Medicare. And to some extent, we've come full circle and back to our civil rights, where just last week, the department announced the Notice of Public Rulemaking for Section 1557 to end discrimination in our healthcare system by ensuring that we have no discrimination based on individuals' sex and sexual orientation, as well as in strengthening our provisions for those with limited English proficiency to ensure that they have equal access to our health and healthcare programs. We still have a ways to go, but there is much that we should reflect on as we move forward. And we know that with the work that has happened, it takes all of us. And one of the provisions of the Affordable Care Act was the creation and establishment of offices of minority health throughout a number of the agencies of HHS. Many of these agencies already had offices, but one of the new ones is the CMS Office of Minority Health. And we work together to ensure that across the department, as our programs and policies have grown over the past 50 years and continue to grow, that there's a spotlight being shed on the needs of our populations that we focus on within each of these agencies. Because we can't do it from one central perch. But we also work together to implement the HHS Disparities Action Plan and the activities related to that, and many other things that we'll talk about. From the standpoint of today, when we think about the CMS equity framework, it's really kind of what guides us on our path to health equity. And it's very simple, honestly, but we call it USA. We want to increase our understanding and awareness of disparities. We want to develop and disseminate solutions, and we want to implement sustainable actions. And it's through these three steps that we think that we can achieve health equity for our populations. And it's this framework that's guided our agenda for today. We'll start by reflecting and kind of understanding and awareness of our disparities and where we've come, having panels to reflect on taking action and some of the solutions that we have across our stakeholders, as well as what we're doing within CMS and others to ensure equity for our populations. Again, we hope that we are on a journey, and we hope you'll join us on that journey. And as we think about where we are with our path to equity, we want to encourage you to tweet and to share your thoughts about the day, as well as what you're doing in your work to help achieve health equity. And so we encourage you to share it, hashtag CMS, Path to Equity, along with our other colleagues. So with that, I'm going to go ahead and kick us off and get us started. I think we have a very exciting day ahead of us. And I would start with our first speaker, who is Dr. Michael McGinnis. Dr. McGinnis is a physician and epidemiologist with a long history and leadership in health and healthcare. He's currently senior scholar and executive director of the National Academy of Medicine's Leadership Consortium on Value and Science-Driven Healthcare. But he has been a longtime contributor in health and healthcare. During his time at the National Academy of Medicine and its predecessor, the Institute of Medicine, Dr. McGinnis initiated a number of initiatives, including a program on national innovation collaboratives, which currently includes the Digital Learning Collaborative, the Clinical Effectiveness Research Innovation Collaborative, the Value Incentives Learning Collaborative, the Systems Strategies for Health Innovation Collaborative, and the Care, Culture, and Decision-Making Innovations Collaborative. He previously served as the founding director, respectively, of the Robert Wood Johnson Foundation's Health Group, the World Health Organization's Office of Health Reconstruction for Bosnia, the Federal Office of Research Integrity, as well as the Federal Office on Disease Prevention and Health Promotion. He also has been distinguished as a recipient of numerous awards, including the Distinguished Service Medal for the U.S. Public Health Service, the Surgeon General's Medallion, the Arthur Fleming Award, the Wilbur Cohen Award, just to name a few. We are incredibly grateful for him to be here today joining us, and he also served as part of the Secretary's task force on the Heckler Report. And so without further ado, I'm going to turn it over to Dr. McGinnis. Thank you.
Well, thank you very much for the deeply appreciated privilege of being here with you today. The work that we're setting about to consider the developments and the issues that are most compelling for all of us as we seek to reduce disparities throughout the nation is absolutely critical. And I want to thank each and every one of you for your commitment, for what you do on a daily basis to lead the charge against intolerable disparities in health care, and in human condition throughout the world, including this nation. I'd like to obviously give special thanks to Cara James, to Patrick Conway, to Pamela, and to Secretary Heckler, who I understand will be here later this morning. And it'll be a great privilege and treat for me to see Secretary Heckler again. This meeting means a great deal to me. As was mentioned, I had the honor of serving on Secretary Heckler's task force on black and minority health. The thoroughness, thoughtfulness, and vision of that task force report is very much a tribute clearly to the foresight and wisdom of Secretary Heckler in launching the effort, but also to the leadership of our chair, Tom Malone. Tom passed away in 2011, and I hadn't seen him for some years before that, but I think of him often, not alone for his many accomplishments. He was the longtime deputy director of the National Institutes of Health, or even for his vision as a pilot, and Tom loved to talk about his escapades up in the air. He could see farther than most of us most days, but especially for his soft-spoken and unwavering humanity. It was a true privilege to work alongside him. This meeting is meaningful because although I wasn't in Washington in 1965, when Medicare and Medicaid were passed, both the then HEW Secretary John Gardner and the then Assistant Secretary for Health Phil Lee later became longtime mentors and friends, and in Phil's case, a close colleague who gave me the highest tribute he could, one of those mentioned by Cara, an award that he named after the architect of the Medicare and Medicaid legislation, Secretary Wilbur Cohen, a true hero in public service. And I really can't think of an individual whose public service career made more difference to the health and welfare and human condition of people throughout this nation. But in many ways, the meeting is most meaningful to me for what Medicare and Medicaid has meant in establishing and in growing our capacity to address key health disparities whose consequences are sealed in my early career memories as faces of patients who died too soon because they came too late to health care. The young, overweight woman whose first visit for care was for nosebleeds that wouldn't stop. She was found on exam to have a blood pressure of 230 over 180, already had substantial kidney damage, and soon went into total renal shutdown, dialysis, and transplant while still in her 20s. Or the 47-year-old construction worker who had what he thought was persistent indigestion. And even though he smoked, had hypertension and high blood cholesterol levels, didn't get checked until he showed up at the emergency department with acute chest pain radiating down his left arm. He was diagnosed with a subendocardial infarct, admitted, and the next day had a cardiac arrest. Or the one-year-old girl whose first postnatal encounter with medical care was when she was brought in because of fever and trouble breathing and died the next day from pneumonia caused by a vaccine-preventable disease. Now, these are circumstances that repeated over and over again for many years, and most people in this room who are physicians or nurses, or for that matter, family members, have their own stories about when these preventable problems occurred, each one a tragedy, but each one now less likely as a result of the gains of the past 50 years and of the past 30 years and even of the past 6 years. Even though our gains have achieved better access to the medical services we need, and our gains in quality have improved the likelihood of the success of that access in changing the state of play, our gains in knowledge about what it really takes to ensure healthier futures for all have made clear how different our strategies have to be. We simply can't incrementalize our way to the kind of changes necessary to reduce the disparities that exist in our society. And that in itself makes this CMS-sponsored meeting meaningful on another dimension. With CMS's ACA-embedded focus on population health, the CMS of Kara James and Patrick Conway and Andy Slavitt is a very different health financing agency from the one I asked in 1980, acting as the department's point person for prevention, to propose a coverage initiative for packages of established essential preventive services under Medicare and Medicaid. What could seem more sensible? Kind of a classic no-brainer, right? Well, the answer I got back directly from an actuary, who I hope is no longer in the audience, said it couldn't be justified because such a proposal couldn't be cost neutral unless it could prove, one, that it wouldn't be cheaper to treat the conditions than pay for their prevention, two, that those who lived wouldn't require support for additional health financing over the course of their extended lifetime, and three, that those longer lives wouldn't draw down further on Social Security and social services, if you can believe it. I should have saved that note, but I didn't. I did call up the head of then Heckler and said, I have in my hand tomorrow's front page article in the New York Times, which it wasn't. But what it did do, because the implication was stark, so stark, in fact, that it prompted us to establish the U.S. Preventive Services Task Force outside the department as it formally reviewed the evidence base for each service and developed a compelling, undeniable case for the delivery and payment of clinical preventive services. Today is a very different day. CMS has fully declared its responsibility as a public health agency and its commitment to raising the nation's sights out of the weeds toward the focus on being as effective and efficient as it can be in improving the health of a population it serves by improving performance in the systems that serve them. If you'll bear with me for a few minutes, I'd like to illustrate some of the challenges and opportunities with a story that may seem to stray a bit afar from today's conversation. Indeed, it'll stray thousands of miles afar to Bosnia. Since our focus is on events that occurred at various mid-decade points, 1965, 1985, I'm going to take us to 1995 for a few minutes. And I'd like to talk to you about Mirza's mom. In 1995 and 1996, after the signing of the Dayton Accords, I served in Sarajevo as the chair of the World Bank European Commission Task Force to rebuild the health sector in the Balkans. The Bosnian War was a 4-year nightmare of ethnic atrocities that accompanied the breakup of the former Yugoslavia, wrenching neighbors from neighbors, friends from friends, family members from family members, and introducing, at least to me, the most heinous of euphemisms, ethnic cleansing. In some areas, we could drive miles and miles and miles past deserted villages, villages whose residents, solely because of their ethnicity, Muslim or Croat, had been expelled or killed. In every war, there are civilian casualties, but this was a war in which the primary targets were civilians, and over 4 years, 3/4 of the population was displaced and 200,000 were killed. And that's in an area not much bigger than some of our large counties. Mirza Muminovich was a young medical student whose studies had been interrupted by the war, and he came to work at our headquarters in Sarajevo. Sarajevo, you may recall, was a divided city during the war. The Serbs in control of one side of the city and the suburbs, and on the other side, largely in Muslim control, with the two sides divided by the river Sava in the middle. Sarajevo was substantially destroyed by the shelling, which mostly came from the hills on the Serbian side. Olympic housing, this had been the Olympic epicenter. Those of you who are old enough to remember the beautiful scenes from the Winter Olympics in Sarajevo will have a sense of the magical nature of it. It really was a spectacular place. I had the privilege of visiting there in the early 70s. But Olympic housing that had been built was reduced essentially to empty high-rise shells. Windows and walls were all blown out. The Olympic Stadium fields, which were about half a mile from my apartment, were converted to makeshift graveyards. Hospitals took their operating suites underground and built steel spines up the center of the building in order to protect against shelling that was coming from one side. My own apartment was in the center of Sarajevo, had plastic sheets for windows that had been blown out months before. I arrived after the shooting stopped, for the most part, but there were bullet holes in the wall opposite the windows in my apartment. We had no gas, no electricity, running water restored by that time for enough each day to fill a barrel. And when I first arrived, our major preoccupation was with tanks and occasional sniper fire, but slowly peace took hold. And one of the other magical elements of Sarajevo appeared. That is the transformation of a totally destroyed city in a very short period of time, a few months, from one that was beaten and depressed and gloomy to one in which it seemed every 24-year-old in Europe was visiting. In fact, 4 months into my tenure, after the snow melted and the tanks had made way to automobiles, spring came with the smell of a rejuvenation that was tremendously empowering and faith restoring at some level. The Sarajevo suburbs, which had been so divided throughout the war, were gradually and systematically returned to unification. And when the last of the Sarajevo suburbs was scheduled to be returned by the Serbs to unified control, and on the day that the bridge opened from where we were just to the other side, Mirza came to me and he asked if we could use one of our UN Jeeps to cross to the suburb just on the other side to visit his mother. Well, this was the first time that Mirza had mentioned to me that for 4 years he hadn't seen his mother, who was a Muslim doctor living behind the Serbian border, about, as the crow flies, a little over a mile, maybe at the most a mile and a half from our office. It took us a very short time to find the building once we went across the bridge. It was a 7 or 8 story structure, heavily damaged, largely abandoned. We gradually made our way up the staircase. Obviously, the elevator wasn't working. Past apartment after apartment that had been abandoned and destroyed as the Serbian population moved to other places, or at least substantially, or had been destroyed prior by the shelling from the Muslim side. Mirza's mother's flat was on the 2nd floor from the top. So we knocked, and you can imagine the sense of that reunion, the reunion of mother and son. After the initial moments, she offered me some coffee. Gracious as she was, and not thinking twice, I naturally accepted. She then went out onto her patio, the balcony, gathered up some sticks that she had out there, lit a fire to boil the water to make the coffee. That's the way she had scraped and foraged for 4 years to keep alive and to live out her dream of reunification with her son. I asked Mirza's mom how she made it through those 4 years, and she said something to the effect of, I knew my challenges and my strengths. I knew my neighborhood and what was happening. I knew the needs of others, and we worked together. And I never lost sight of what was most important: reunification with her son. And when you think about it, and really one can't help but think a lot about how she survived in those circumstances for 4 years. What Dr. Miminovich did was practice under duress the same basic principles so important for each of us as we seek to reduce persistent disparities. She knew her challenges and her strengths. She was a Muslim behind Serbian lines. She lacked reliable access to food and water. She lived where violence and gunfire was a moment-to-moment reality. But she was also a physician with the ability to help widely in an environment where the primary threat was to life and limb. She used all the creativity she could muster to reduce her risks. In epidemiologic parlance, reliable information and effective engagement of the determining factors is essential. She watched what was going on around her. She spent many of the early months of the war getting the lay of the land. Which sections were controlled by whom? Where was the shelling likely to come from? Where were the sources of water likely to be? Place matters whether you are in Bosnia or in Baltimore, and place mattered a great deal to her. She forged partnerships. She carefully identified the people around her with common interests. She forged those partnerships and worked closely to nurture their strength and the trust of the bonds. Like survival, better health has better prospects as a team event. She focused on the important. Keeping it firmly in mind, her ultimate reunion with Mirza served as her driving inspiration. And while her daily tactics were certainly instrumental to the goal, her focus on the important, on the most important, unleashed the creativity to attain it. Now, I don't want to overplay the comparisons, but they provide a useful set of reference points as we think about what it will take to achieve a healthier future that is equitable and attainable for all. A snapshot of a few elements of the state of play gives us a sense in that respect. Over the course of the last 50 years, of the last 30 years, of the last 15 years, access to care has improved across all population groups. Quality of care has improved at some measure across most groups. Disparities have not been eliminated by any means, but on most dimensions, not all, they are narrowing somewhat. If we look at life expectancy as an example, in 1970, the life expectancy for whites was 72, and for blacks was 64. In the year 2000, it was 77 and 72, respectively. Substantial improvements for both groups. Infant mortality rates have improved similarly, a little more for blacks than for whites, but there is still a persistent twofold difference in those rates. If we look at the circumstance for children ages 1 to 4, for whites, the death rate dropped from 85 per 100,000 in 1965 to 30 per 100,000 in the year 2011. For blacks, it dropped from 175, over double the rate for whites, to 49, a dramatic drop, very encouraging for the children ages 1 to 4, but still is 50% higher. There is a 50% persistent disparity. And for children ages 5 to 14, the rates for whites, death rates for whites, dropped from 40 to 17, a little over half. For black children ages 5 to 14, it dropped from 60 to 21, about a third of what it previously was. Very encouraging on that count. And in fact, the gap between black and white children is relatively small. Also encouraging. Any deaths to children 5 to 14, virtually any deaths, ought to be viewed as unacceptable. For young people ages 15 to 20, the story is very discouraging. The death rate for whites from the late 60s to 2011 dropped from 110 to 75. For blacks, it declined from 176 to 151. A very small reduction over that period of time. Now, when you look at the reasons for those disparities, it is very clear that they don't derive from inside the clinic doors. At some level they do. At some level there's still disparate access to the kinds of services and the quality of services that we need, which is why the CMS initiatives on those dimensions are so important. But fundamentally, the sources of those problems lie outside the clinic doors, and that doesn't mean that health is absolved from responsibility. Health certainly doesn't have all the responsibility, but it has the ability to reach out and form partnerships and build allegiances. It needs a population health perspective of the sort that CMS is committed to building over the course of the coming years. And in doing so, it will be focusing on the importance of reliable information for those issues that are most important to track. It will be focusing on the fact that place matters, that healthcare organizations not only need to be accountable organizations, but we need to have accountable communities. for the improvements that are possible. And we will be looking outside the clinic doors, building and restructuring incentives for those partnerships to evolve that will link arms of the key organizations in order to improve the overall health of the population. And we will and must focus our accountability and measurement on what really matters in reducing disparities, raising our vision above the weed level and to the level of what's possible. These are CMS's challenges, and I'm very encouraged by the leadership that you've already mounted in the past few years to redefine what success means within the organization and to lead the kind of changes that are necessary across the nation. You're incorporating a vision in which we focus not only on adding years to our lives, but adding life and vitality to our years. Mirza's mom teaches us what resourcefulness and knowledge and cooperation and dedication can accomplish. What she taught us is the essence of what you're fostering here today, marshaling reliable information and effective engagement of the determining factors of our health status. Place matters, whether you're here or somewhere far away. Better health has better prospects as a team event. Focus on the important unleashes the creativity to attain it. Thank you for honoring me with your invitation and the opportunity to join in this celebration of progress, the reality test on the challenges, and the promise of the vision that you're creating of healthier futures for all. Thank you very much.
So thank you, Dr. McGinnis, for that. I think that that story is just very perfect in terms of what we need to do and what we have ahead of us. We are waiting on our next speaker to arrive, but in the meantime, we'll take just a couple-minute break while we figure out where he is, and hopefully you will join us in a few seconds when we find him. Thank you.
Our next speaker is on his way. He should be here in less than 5 minutes. He's in the building. Thank you.
Going to give it just a second. We also have another distinguished guest who just arrived, so we're going to give her a moment to get seated before we get started here as well. Okay. So thank you. And I think just kind of reflecting again on some of the things that Dr. McGinnis said, I think he really has led the way to kind of get us started and giving us that understanding. And next, as we have talking about the CMS leadership and some of the things that we're doing as we move forward in developing those, disseminating those solutions, we're very fortunate to have with us Dr. Patrick Conway, who is the acting principal deputy administrator for CMS, as well as the chief medical officer for the agency, and the deputy administrator for innovation and quality. You have his full bio in the booklet that we have, so I'm not going to read through all of that. But just to say that Patrick's leadership is one that really, in terms of changing the agency from its focus and infusing our focus on quality improvement, population health, has really been one that we are incredibly grateful and thankful to have with us. So without further ado, I'm going to turn it over to Dr. Conway.
First, I just want to thank Kara and her team for organizing today. I want to thank all of you for being here. It's really been a pleasure to work with Kara and her team over the last 4+ years now, and they really do amazing work on behalf of the American people, so I wanted to say that up front. I'm going to hit some high-level points overall on quality and innovation, also focus on health equity and disparities along the way. You know, I'll say up front, I still am a practicing physician, work at Children's National Medical Center, taking care of a population that the vast majority are on Medicaid and CHIP, and the vast majority of the children have multiple chronic conditions. So as a practicing physician and clinician, you know, I see firsthand the difficulties our health system still has with delivering high quality care to all Americans. I think our health system still has challenges in terms of disparities in health outcomes that we're trying to resolve, and improved health equity, so I'll try to weave that throughout. I will talk a bit, you know, Affordable Care Act impact. I also talk fast, even though I grew up in a small town in Texas, so I will share my slides if I fly through something. As you all know, expansion of health insurance, decreased uninsured rates, lowest uninsured rates on record, which is incredibly exciting. Now slower growth in healthcare costs, which we continue to monitor, and then improved quality of care. If you think about some of the primary care changes from the Affordable Care Act, things like innovation center models like Comprehensive Primary Care Initiative, which I'll speak more about, independence at home, taking care of chronically ill beneficiaries in their home, transforming clinical practice, which we're hoping to announce the awardees very soon, but up to an $800 million investment to support up to 150,000 physicians and clinicians. There was a direct focus on small, rural, and safety net providers in that funding announcement. Our various state innovation models and community innovation, and also just generally trying to move away from paying for episodic procedural-based care to chronic care management and managing populations with multiple chronic conditions. This slide you don't have to memorize the detail of. It just shows 2010 CBO projections to now 2015. Much lower cost projections, estimated $200 billion and growing savings from the 2010 projections in terms of cost growth. Our own multiple external analyses and internal analyses saying that part of this change is due to fundamental changes in the delivery system. We do think using information to drive better decisions is important, so transparency, for example, in our various compare websites, also getting data out. We're actually working closely on, both in data and in quality measures, how can we reliably have data and quality measures stratified by things such as race, ethnicity, socioeconomic status. So more work to do there, but we think important. things like Hospital Compare as an example, you can see the screenshot here. We are evolving all of our websites, including Hospital Compare, over time to a star-based rating system based on input from consumers and consumer testing and working with the various providers as well. Nursing Home Compare actually is one of the most used federal government websites. So over 1 million visitors per year looking for, where should they receive nursing home care for their loved ones. Our overall frame for delivery system reform is better care, smarter spending, and healthier people. As we think about that, we try to think about what are the incentives, both for providers and for consumers, that bring about better care. We focus on care delivery, which gets to things like integration of behavioral health and the typical physical health arena, and we all know that integration is critical and opportunities for improvement there. We focus on improving population health. So how do you not just focus on the population in front of you, but the population in your community? I can tell you from some work that I did not lead but participated in when I was at Cincinnati Children's. Our biggest change in decreasing preterm birth for our catchment area was actual geocoding of zip codes. In Reeling, we had zip codes with huge disparities in preterm birth rates, and then targeting community-based interventions and home visiting and other programs in those zip codes, and able to decrease substantially the preterm birth rate for the Cincinnati area. So I think, one story, but I think a similar story could be told in many geographies and states and communities around the country, that you really have to narrow down using data on what's the population at risk, how do we intervene in this population in a way that's successful, including thinking outside of our traditional care delivery frame to things like community health workers and other interventions. Information, as I talked about, we think is a critical piece of this, both information on overall quality of care, but also how that quality may vary in different populations, and if there is a disparity in care, how you eliminate that disparity. I'd be remiss if I didn't talk about the Secretary's goals. Also, the President was involved in this announcement, but shifting our payment system to alternative payment models and value-based care. So goal number 1, at least 30% of payments in alternative payment models where the provider is accountable for quality and total cost of care for the population served. So these are things like accountable care organizations or comprehensive primary care models, and then 50% by 2018, and I'll show you some data on where we are now. And then goal 2 is value-based care, so linking payment to quality and cost, 85% by 2016 and 90% by 2018. We do worry about unintended negative consequences here. As you shift payment incentives, there's a risk that you could have populations where you actually exacerbate disparities. We're trying to take a number of adjustments, including one I reviewed last week that I can't talk about, but around how should we think about risk adjustment? How do we think about quality improvement and support for various providers? How do we think about the measurement paradigm? So, I think sometimes it's a challenge as an agency. We're never supposed to get ahead of sort of where we are publicly, but I can tell you this is an issue that we focus on a lot. I care about deeply, I know, Kara and her staff, and we probably still have more work to do. And then we launched this Learning and Action Network as well, announced by the President on partnering the private and the public sector in this transformation, because we know that this change, it can't just be driven by CMS or from federal payers. It's really got to be driven by states, communities, providers, payers, employers, people driving frontline change in the healthcare system. I've been sharing this recently. This isn't my study, it's Harlan Krumholtz, and he actually did use the jaw-dropping quote, which I was like, wow, that's not a typical academic researcher quote. But I called him and thanked him for that. This was his analysis of Medicare data. If you haven't seen it, from 1999 to 2013, you can see all-cause mortality decreasing significantly, total hospitalizations per 100,000 beneficiaries also decreasing significantly, expenditures decreasing significantly, and end-of-life hospitalizations decreasing significantly. So his point was, if you look at the macro picture of Medicare changes over time, dramatic reductions in mortality, improvements in quality, and improvements in experience of care. Still more work to do in my fundamental being. I'm a quality improvement person. So I think, real issues that we need to tackle, and I'd highlight, especially given the theme of this conference, we still have pockets of healthcare delivery in the U.S. that are incredibly poor, that are delivering suboptimal care with things like negative birth outcomes, death that could have been avoided, so major impacts on people across this country. So I think collectively we want to improve the entire health system while concurrently we're improving care for populations of patients that still have significant gaps in the care delivered. I'm now going to pivot a bit and talk about some of our specific work. One in our Million Hearts initiative, which is focused on blood pressure control, aspirin, cholesterol, and smoking, and preventing 1 million cardiovascular events. A focus on eliminating health disparities has been a major focus of this work. We know cardiovascular outcomes can be worse in a number of populations. We've worked with Kara and her team trying to target the interventions to reduce disparities and are making some progress. In our QIO statement of work, this is the Quality Improvement Organization program. To spell out some of the acronyms, I apologize. I'm using a new set of slides, which is always an interesting experience. Is one of our major investments in quality improvement via the QIO program. I'm going to talk about a few areas here where we've made investments, such as reducing disparities in diabetes care and our readmissions programs and care coordination programs, really targeting those communities and hospitals with the highest readmission rates, for example, to try to eliminate disparities in care. The Everyone with Diabetes Counts project is a community-based intervention targeting minority and rural populations, largest government-funded diabetes education program focused on minority and rural populations, and engage both beneficiaries and healthcare providers to improve clinical outcomes and increase diabetes education and management. I see Jean in the room. Jean was maybe in the beginning of this project, almost in the beginning of this project. And I see a number of folks. Yeah, this is terrific. So great to see people who started this work here. So I cannot take credit for it, but started as a pilot project in Florida 7 years ago, expanded to 9 states, and now, as of August of 2014, national expansion through the Quality Improvement Organization program. So an example where demonstrated results in terms of care delivery and reducing disparities, and now scaling the program nationally. And it's the largest Medicare diabetes self-management education program in the country. Okay. Some of the goals, just briefly: improve health equity by improving health literacy and quality of care among Medicare and duly eligible beneficiaries with diabetes. So the patient engagement is core to this work, and also engaging people in communities to engage with patients. It is a disparity reduction population because we're targeting minority, underserved, and rural populations, focusing on outcomes that you could imagine, things like hemoglobin A1C, eye exams, foot exams, blood pressure control, and weight control, so evidence-based interventions for diabetes, really improving clinical outcomes for the population served, and then facilitate, and this is key, sustainable diabetes education resources by engaging at the community level, public and private agencies and organizational partners, so that it becomes a sustainable model of improved care delivery in the community. I'm now going to shift a bit and talk about the Innovation Center. I will not talk about all these models, lest you think I will run over time, but I will talk about a few. First, partnership for patients, major investment in patient safety in this country, partnering. I see Bruce in the audience and probably others that have really driven the improvement work here. Really focused on improving patient safety at scale. So the goal was reduced patient harm and reduced readmissions. Patient harm shown here, this is from the ARC National Scorecard, so it's random sample chart review data, so gold standard data source. 2010 to 2013, 17% reduction in all-cause harm, That's an estimated 50,000 lives saved, 1.3 million injuries, infections, and adverse events avoided, and $12 billion in cost savings. So I think shows the power that when government funds quality improvement work, and importantly, partners with people in states, communities, provider organizations, that we can drive national major quality improvements. The last one, as a pediatrician, I'll call out early elective delivery, which is a major risk factor for preterm birth and complications, down 70%. So major reductions in early elective delivery. Once again, a partnership model to drive this work. This is not me or CMS. This is a partnership model improving care across the U.S. On the next slide, Pioneer ACOs. So our ACO program, I won't bore you with all the details, but over 400 ACOs now serving 8 million and growing Medicare beneficiaries. The Pioneer ACO model was the first model certified by our actuary that improves quality and lowers costs. You can see here, over $300 million in total, or over $400 million in program savings. Quality, which I was most excited about, started at a high level, above published benchmarks in quality. Year 1 to year 2 to now year 3, dramatic improvements each year in quality and patient experience. So improved on 28 out of 33 measures, for example, year 1 to year 2. Similar improvement year 2 to year 3. So showing when we deliver coordinated care to populations of patients, it's a better quality care, better patient experience, and lower costs. So the classic triple aim. Comprehensive primary care, the model is partnering with private payers and putting in population-based payments into primary care to really move primary care practices away from fee-for-service to care coordination to populations of patients. A few key points in this model. All the private payers and the public payers, including Medicare and Medicaid, agreed on the exact same 13 quality measures. We all agreed on the same basic structure, accountability for total cost of care and quality measures, and we all put in population-based payments into these practices. I'll just tell you about one, SAMA Healthcare. This is in rural southeast Arkansas. They serve a very large patient population. Redesign their care teams, classic quality improvement methods, using their electronic health record to segment patients based on risk, using telehealth and remote monitoring to interact with patients outside of the office visit across rural Arkansas, visiting patients in nursing homes when they get admitted to nursing homes, doing home visits when needed for patients with medical complexity. Two quotes from their leading physician who, last time I spoke to him, said, number one, his patients love it. They have no idea that they're in an innovation Obamacare-funded model, but they love that they are getting the care, they're getting the pharmacists that talks to them about their medications, home visits when they need them, they all know which team they're on. They all wear colored scrubs. This is like classic QI. And they're like, I'm on green team. So very engaged patient population. Actually using providers, I should say, these are true teams. So physicians, nurse practitioners, pharmacists, social workers, whole team, including community health workers. Second thing he said, which I think is critically important to note, he said, I'm finally practicing medicine the way I want to. I've been practicing 30 plus years. I'm finally practicing medicine the way I want to. And he was a very honest person. He's like, and let me be clear. The dollars you put into my practice, all the payers, I would have mortgaged my house 5 times over. So there was a reason that I did not make this transformation at this rate earlier. By the way, the dollars that went into this practice, the ROI in the first year was 3 to 1, actually a little greater than 3 to 1 in terms of their return on bringing down total cost of care. So I think, we need more practices like this one that are driving transformation. I see Marshall in the room. I know, harder to do at scale, so I don't want to minimize that. But I think shows the power of what the transformation can look like. State innovation models, in the interest of time, won't go through these in detail, but we are working with 38 states and territories on comprehensive delivery system reform. A couple examples, Minnesota is working on accountable health communities, where they're really linking the social and public health services with the clinical care delivery system. From that innovation model and some other work, we're actually thinking about launching a much larger model on accountable health communities out of the Innovation Center. Arkansas is doing primary care redesign and bundled payments, including a bundle that's from pregnancy through 1 year post-term, really interesting model where with Medicaid mothers, making it clear that an investment in the pregnancy phase can actually have large dividends from improved care, decreasing preterm negative outcomes, et cetera. So those are just a couple examples. Vermont's working on an all-payer ACO. So going forward, what's the Innovation Center focused on? Implementing models, monitoring and optimizing results, really focused on the evaluation and scaling issue. I'm having some technical difficulties. We are focused on integrating innovation across CMS. We work closely with Kara and her office, who have been tremendous in this work, and then did some analysis and have been launching some new models. Just to call out one, Care Choices, where patients, for the first time in Medicare's history, will be able to receive hospice and palliative care services at the same time as curative care services. So really testing a model that allows patients to see and their families to receive the care that they want, when and where they want. And we got a huge number of applications for this model and announced we're launching over 140 across much of the United States. So this is the last slide. I think collectively we have to focus on things like eliminating patient harm, focusing on better care, smarter spending, better health for the patient population we serve, engage in accountable care and other alternative contracts. I do think, as I alluded to, we need to think about how we structure these in a way that all types of organizations serving all types of patient populations can be successful. And I think we still have some work to do there. I do think we need to invest in the quality infrastructure necessary to improve, focus on data and performance transparency, additional research to inform both policy and the implementation of these changes, testing new innovations and scaling rapidly, a constant focus on health equity and reduction of disparities, and relentlessly pursue improved health outcomes for all. So with that, I will stop. I want to end where I started. I want to thank you for having me here today. I want to thank you for all the work that you do across the United States. See many leaders in the audience, and really appreciate your time this morning. Thank you. So I also have the honor of introducing the next speaker. So this will test me. And we met in the hall, just a tremendous background. So thank you so much for being here today. So Secretary Margaret Heckler convened the first group of experts to conduct a comprehensive study of the health status of minorities in the early 1980s. What resulted was the report of the Secretary's Task Force on Black and Minority Health, also known as the Heckler Report, which elevated minority health to the national stage. It served as a driving force for monumental changes in research, policies, programs, and legislation to advance health equity at the national, state, tribal, territorial, and local levels. The findings and recommendations of this report, released in 1985, helped to chart the work ahead in addressing health disparities for future generations. This year marks the 30th anniversary of the Heckler Report. 2 years prior to its release, Secretary Heckler noted in an annual report of the nation's health that while health and longevity of all Americans continue to improve, there were significant disparities between non-Hispanic whites and racial and ethnic minorities in the United States. Secretary Heckler also noted that the sad and significant fact of a continuing disparity in the burden of death and illness experienced by minorities. Secretary Heckler subsequently established a task force on Black and minority health, which represented the first U.S. government group of experts that convened to conduct a comprehensive study of the health status of minorities. The findings in the Heckler Report were a landmark in our understanding of the extent to which racial and ethnic minorities experience significant health disparities. Thank you, Secretary Heckler, for being here with us today. Thank you.
Thank you very much. Thank you so much, Dr. Conroy. What a pleasure it is to be here today. To be with all of you in this very impressive building. I'm very delighted that the Heckler Report has brought us all together in one small way. And each of you has been participants in the development of the continuing story of American health. You may wonder how such a thing began, and I'll share a story with you. As a child, I knew a woman who's an African-American lady, very knowledgeable, very brilliant, very kind, and very helpful. She left a mark on me, and I always remembered her. Her name was Christina. And when I became Secretary of Health and Human Services at the appointment of President Reagan, I was very interested in, of course, learning everything about health and health care. I had served in Congress for 16 years. I had been a lawyer, but I also had been on the Veterans Affairs Committee, and that was my introduction to health for 16 years. That I was considerably knowledgeable on that subject. I had to learn everything about health care in the broader sense. And one of the first things that I did, of course, was to try to read everything possible and gather the data that might be available for the decisions that I was going to have to make. And I was quite shocked when I learned of the disparity in longevity between African Americans and the white population. And this surprised me so much. It reminded me of Christina, this wonderful woman who was so bright and so able and so helpful throughout my childhood. How is it that her outlook for longevity, her lifespan, was likely to be limited beyond anything I would have expected? And my approach was to find out what could be done about this. For the first time in my life, there was an opportunity for me to make a difference, not because I had such a knowledge of healthcare, but because I was surrounded by the experts of HHS, and the department that I headed, and the experts in the private sector. And so I commissioned this first study of Black and minority health. The results were amazing. The advocates and those who've been caregivers in the field came forward with their voluntary contributions. 9 volumes of information were collected and published and available now for history, because that was the beginning of the study which led us to our meetings today, to our Office of Minority and Black Health. Our feelings, this particular experience in bringing the experts together and delving through the archives and also through the medical histories available, through the personal testimonies that people offered, was the beginning of a new approach in healthcare. Earlier, we had data primarily from white males, and of course that was inadequate in my view. But beyond that, this was hardly the fundamental research available for the kind of healthcare changes that we espoused as Americans, for all Americans, that all would have equal opportunity and access and care of the highest quality. This American experience was very much bolstered by the expertise and the information which the Heckler report gathered, and it was the beginning of our new approach to healthcare and to healthcare study. And as we come together today with the experts that we have heard thus far, with Dr. McGinnis, who was one of my mentors, very available and so brilliant, and so particularly incisive in his analysis and his expertise. His presence today is very meaningful to me, as is Dr. Conroy. I'm so happy to see that the accomplishments he's achieved here at CMS have culminated in this incredible meeting and in this 50th anniversary of Medicare and Medicaid. And Cora James, Dr. James, the director of the particular section involved with the minority health care issues, hosted me today, and I thank her for that invitation. We are all here to look at the difficulties of our American healthcare system. As I did in 1985, when it all began. We look back and see how different life is today than it was then, and how much more needs to be done in every area. Our eyes are sharpened, and our capacity to heal, to deal with the problems of the American population has increased as we gain more information, more scientific knowledge, and more expertise. This is the product of, and this is the opportunity for this meeting, which will lead us into new passages and new opportunities. Nonetheless, the challenge continues on for the, as I have to congratulate all of you who have been part of this, because many of you have been along the way with your own testimonies, your own involvement, your own experiences that have been shared and being shared constantly in this evolving story of American healthcare. As we stand here today and ponder what the future will hold, I have to rely on the time-old sentiments and the mantra of my own life in looking toward issues of great importance and of great seriousness. And my own mantra was very simple: work hard, study hard, pray hard. And some of you may be surprised at the last comment. Nonetheless, I feel it has been one of the most powerful areas of my growth. And I say so with full respect for all religions, and also our American freedoms, the right not to believe in anything more than ourselves. In fact, I have found the contribution of science and theology is much more compatible than I would have thought in the past. Science is moving ahead, but the creator of creation is also aware and in the leadership, in my view, and in my mind, and in my belief system, in the leadership of all that we are doing. We're searching for that goal of pure, excellent health care for all, at all levels. And as we do this, I congratulate you for being a part of it, for the roles that you play as part of the collaborations of the expertise of our nation. As important as CMS is, it cannot be replaced with any other system in the world, and nothing is equal to it, both in its goals and its strengths and its capacity to reach out. And so the crisis and the challenge remains. Nothing has been resolved, but much has been learned, and that, I'm happy to see, began in some measure through the Heckler report. I congratulate you for your participation at all levels, and your continuing to serve the challenge that grows, the challenge that we all face. We are in this together. We are all Americans. We have to take advantage of every opportunity to learn the best science, investigate the best science, follow our hearts, and also share with others the contemplation and the outcomes that we have witnessed and been part of in our journey through this healthcare field. So I just join you today in that spirit with great joy that the beginning questions that have been asked and answered by so many on the panel on the first team, and Dr. McGinnis was one who was very helpful from the very beginning. We are 30 years later, and much has been done, but much more remains to be done. I feel very strongly that the most important thing today is to realize that we are in this together. We are not black and we are not white. We are not Asians, we are not Hispanics. We are Americans. And it's the American answer which will lead the world in healthcare. If we work together, not in our polarized particles, in our polarized section where we pay attention to only one thing and one group and only our own interests, the result will not be the same. But working together as a team, as we all are, for what is best for America, what is best under the Constitution, to achieve health care for all and access for all at all levels of our society. Working together, for better or for worse, will achieve the great goals, the greatest goals that we have in our hearts. May God bless you in your work. I congratulate you. May God bless America.
Thank you so much, Secretary Heckler, for those words, and especially for your commitment to be here today. Those of you may not know, the Secretary's been under the weather of late, and we are incredibly grateful that even as such, she took the time to be here and felt that this was such an important occasion that she was really committed to coming. So I thank you on behalf of everyone. So I think we are now going to turn it over back to Pamela.
That sounds great. Oh, we got through the morning, and I think it was very exciting, and I hope you're all enjoying yourself. We're going to now take a 15-minute break, and we would like to ask all of you to actually exit the auditorium. We're going to be moving the lights in the front, and for safety reasons, they've told me we can't have the auditorium filled. So you all have 15 minutes. Enjoy yourselves, and we'll see you promptly back here. Thank you.
Is that good? You can use voting. Is it worse that the, it's like a laptop, so that's, you just use slides there? Yeah. I don't know why
Forward. Okay. It should be. Oh, there it is. Somebody fool with us. There we go. So is each speaker speaking from the podium or from the driver? Down there.
Oh, they want to speak from there?
Yeah.
So in terms of advancing slides then,
Have a clicker
okay,
and
clicker's down there.
see.
Okay, so you want us there?
Yeah.
Okay.
So you'll be first up. Oh, okay.
But I don't have any more slides. Click that. Just make sure
Okay.
so. Okay, okay, good. Great.
I thought we'd all be getting on the podium until I found out this morning that they want us each to speak from here. It's different. Well, it's just it's only those three that need to see it. That's why we tilted it a little bit. Because I'm just.
Yeah, it's here. Okay.
It was just there. It's on. We'll start with Marshall and then Kelly and then you.
It looks like you want us to speak from here as opposed to.
Yeah, I was asking Chris, and thanks for setting this up. And it's way.
No, otherwise, I didn't even think about everybody having to turn their back. So.
Oh, I see. Excellent.
Yeah, so this that's the line. Forward is on the left.
I guess they will.
That's counterintuitive.
Yeah.
Thank you all so much for your cooperation, and glad to see you all made it back safe and sound. At this time, I'm going to turn the program over to Dr. Chris Heckler, who is part of the Office of Minority Health, and he will be leading our first panel of the day. Chris?
Thanks. Good morning, everyone, and welcome back from your break. My name is Chris Hafer, and I am the Director of the Data and Policy Analytics Group here at the CMS Office of Minority Health, and I am in the enviable position of standing between you and lunch. So 30 years ago, and I'll read directly from the Heckler report, the task force acknowledged that the factors responsible for the health disparity are complex and defy simplistic solutions. Health status is influenced by the interaction of physiological, cultural, psychological, and societal factors that are poorly understood for the general population and even less so for minorities. Even though the shared characteristic of economic disadvantage among minorities suggests the possibilities of common approaches for achieving improved health, diversity within and among minorities necessitates activities, programs, and data collection tailored to meet their health needs. Today, there is growing recognition, both societally and legally, that you're tired, you're poor, your huddled masses yearning to breathe free includes all of us. No matter the color of our skin, our gender, who we love, or the physical or intellectual gifts we've been given, we are part of the fabric of America, and our health, as well as our access to high quality, culturally appropriate, affordable health care, should not be limited as a result of who we are. Today, I have the honor of moderating what, in my humble opinion, is the most important panel you will hear all day, Where to from here. Our distinguished panel focuses on just that, the diversity within and among all minority groups, and the challenges and opportunities we face moving forward. It is my great pleasure to introduce our speakers, Marshall Chin, Kellen Baker, and Gloria Cron, each a superstar in the field, and over the next hour will share with you their thoughts on where to from here as we think about improving health equity for people of color, sexual and gender minorities, and people with disabilities. We ask that you jot down and hold all of your questions to the end. We've allotted 30 minutes after the last speaker for questions and answers. Without further delay, please join me in welcoming our first speaker, Dr. Marshall Chin.
Thank you very much, Chris. It's a great honor to be here, and it was great to see Secretary Heckler. I'm from Massachusetts originally, and so my image of Secretary Heckler is actually Congresswoman Heckler, the beloved Congresswoman from Massachusetts 10th District. So here are my disclosures. The closest to a for-profit is Merck Foundation, which is a philanthropy funded by Merck Company. I've been on a couple of the National Quality Forum equity committees, and then I provided some technical assistance on equity issues to CMS unpaid. I mentioned too that it's great to be here in this audience with so many like-minded people that are passionate about equity issues and want to make a difference. I've also worked with many CMS people over the year, and there's just been tremendously bright, talented, committed people also. And so in many ways, I feel like I'm with family here. And as with friends do, I will do what friends do, which is to be honest with you. And my main message is that we've made progress in equity, but there's a lot more that all of us can do, whether we're clinicians, healthcare organizations, insurers, or CMS. And CMS in particular has a lot of influence. And in some ways, I believe that unless CMS takes the next step in terms of working on equity, we're not going to get there as a nation where we need to go for reducing healthcare disparities. I'm going to describe a 6-step roadmap for reducing healthcare disparities. I'll be outlining a conceptual model for interventions to reduce disparities, and I'll be ending by suggesting some ways for CMS specifically to transform the nation to achieve healthcare equity. I'm going to start with 2 stories. So I'm at the University of Chicago, and I've been there over 20 years. And for about the first 16 or 17 years I was at the institution, there was the same chief financial officer of the medical center. And he would go to each department each year and give basically the financial story of the university. And his story was basically that at the University of Chicago, like many academic medical centers in a predominantly fee-for-service environment, it's a relatively small percentage of the patients that bring in the money institution. So at the University of Chicago, and I think it's probably fairly typical, is 5% of the patients. So these are things like organ transplants, orthopedic surgery, gastrointestinal procedures, hematology oncology. So it's a relatively small number of the patients. And so a lot of the strategic plan was involved, how do you increase the flow of those patients to the university? So about the 3rd time I heard the talk, I raised my hand and said, well, isn't it a little bit risky basing the financial strategy on only 5% of the patients? And what he told me was, well, Marshall, smart aleck, someone has asked me that question each of the past 15, 16 years, and my answer is always the same. Has anything occurred that would make me change that financial strategy? And at least half a dozen years ago, I had to be silent because he was right. The things were not changing. Well, if we fast forward to about 5 years ago, the new dean came. This is Ken Polonsky, who's our current dean, and he basically turned over 90% of senior management. And for the first time, really, in a serious way, I think, the university started working on equity issues and population health in our surrounding south side of Chicago neighborhood in a really serious way. And I think for Dr. Polonsky, it was two different issues. One was it was the right thing to do, that he's South African and he grew up in the height of apartheid. And he tells stories of seeing the effects of apartheid and the demonstrations where the secret police would film the crowd of students. So it was pretty scary times. But I think I'm also not naive enough to believe that, well, it was just that for Dean Polonsky. Part of it was the business case, that the financial incentives were starting to align. More global payment, ACLs, bundle payments, more at-risk contracts for Medicare and Medicaid. And I think that a lot of the Chicago market, including University of Chicago, they were scared in terms of wanting to be prepared for these new financial models, and therefore population health and thinking about the community became more important issues. Also, the community needs assessment for nonprofits. My second story, so I do a lot of work with federally qualified health centers, and full disclosure, I'm a fan of federally qualified health centers. Used to work with one in Boston's Chinatown. And so one of our products involves working with a number of FQHCs in the south side of Chicago, trying to improve diabetes care. So about 5 years into our project, we had sort of a check-in with the leadership of the different centers, and this is one of them, Chicago Family Health Center, outstanding health center, mission-driven, they do things for the right reason, very good health center. And they were saying, well, we love what you're doing in terms of trying to reduce disparities in the south side of Chicago, but to be honest with you, we can only go so far because of the financial model. So the two stories really are that, whether it's the University of Chicago or whether it's a federally qualified health center, there's only so far people can go before the financial model limits them. And this is a reminder of health disparities in Chicago, but it really is anywhere. African Americans, south side Chicago, for diabetes, we do a lot of work. But one out of every 5 people have diabetes. And if you live in one of the predominantly African American neighborhoods of Chicago, you have 3 to 5 times the rate of having your leg amputated than if you live in one of the predominantly white neighborhoods and you have diabetes. The past 3 weeks I was on the wards, inpatient wards, including this past weekend. We had 4 patients, African American with diabetes, who all were admitted for amputation. It's a preventable condition. And again, just as a reminder, we're all familiar with the challenges of the inner city in terms of poverty, food deserts, crime, but oftentimes we overlook the great strengths of the community in terms of the historical and cultural institutions and the healthcare institutions. So just to let you know, some of this part of this talk, a large part of it is based upon work from a Robert Wood Johnson Foundation program we led over the past 10 years called Finding Answers, Disparities Research for Change. Our website, solvingdisparities.org. And the lessons are coming from our grantees, which were 33 grantees doing intervention disparities work, 12 systematic reviews of the disparities intervention literature, and then we provide a lot of technical assistance to frontline organizations, learning from the School of Hard Knocks in some ways what works and what doesn't. So basically providing information about what works, what doesn't, and creating tools and resources now on our website. National program, grantees from all over the country. And then the groups we provide technical assistance to, again, are national. So we have a pretty good feel for what has worked nationally. And for those of you interested in more details from my talk, Journal of General Internal Medicine 2012 article available on our website. And this roadmap I'm about to present to you, so I've given elements of this talk many different times to a lot of different diverse audiences, and uniformly people like this roadmap because I think it resonates with people's practical experience, regardless if you're a clinician, a provider, or insurer. So the dirty secret is like your 15 seconds of fame that literally this flashes at Times Square for 15 seconds for 3 or 4 times. So here's the roadmap, 6 different steps we'll go through in more detail. I'd like to point out a couple of them in particular for CMS. CMS really is involved in all 6 of these. 2 of them in particular, the commitment to change, and this is something that Dr. Kara James has spoken eloquently about in the past, and trying to increase the commitment to change. And number 6, and where CMS really has a unique opportunity, and really only CMS can do this, sustain the interventions and really the financial models. So the first step of this roadmap was recognizing disparities and committing to reducing them. Two different elements. One is examining your performance data stratified by race, ethnicity, language, and data, and language. And what this does really is increasing people's motivation to change. And so you've probably seen the studies where almost all clinicians believe that health disparities exist somewhere in the country. But when you ask them, how many of you believe it exists in your own personal practice, the number drops from basically 90% to 40%. Point being that until people see their own numbers, they're not going to be convinced that disparities exist in their own practice, and they won't be motivated to work on it, therefore. And again, CMS, this is sort of low-hanging fruit for CMS in terms of being able to require reporting of stratified performance data. The second issue you hear about is cultural competency training. And so here are the Society of General Medicine goals for cultural competency disparities courses. So describing the existence of disparities, the causes, the solutions, talking about mistrust and subconscious bias, communication and trust building, a commitment to reducing disparities. University of Chicago, there's a course that's required of the incoming first-year students right off the bat for one of the first two courses they take. And so there are the different elements here on the course that are mentioned. So self-insight exercises, for example, field trips to the South Side of Chicago. I want to point out the last bullet, though, advocacy. So over the past couple of years, and this is a course that's been offered now about 10 different years, advocacy has specifically been put into the course. And we've done that because we found that for the students, unless there's the advocacy component, they feel disempowered because, you know, if you hear about disparities, you get cultural competency training, but you don't have more powerful interventions, people in some ways feel that they just don't have the power to change disparities. So advocacy systems interventions have become a fundamental part of the course. Do they work, you know, these stratified performance data interventions and cultural competency interventions? Well, the bottom line is that these stratified performance interventions, they're helpful for increasing awareness, but they're not sufficient for actually improving clinical performance measures. Your standard HEDIS measures, for example. Similarly, cultural competency interventions, they improve knowledge and attitudes, but they're not sufficient to actually improve clinical outcomes. In some ways, it makes sense that, you know, data shows us the problem, but they don't show us how to improve the problem. So I point this out because I think too many people in the disparities field have sort of relied upon the data themselves and cultural competency interventions to be the magic bullet. But, you know, there's actually good data that they are helpful, probably necessary, but not enough to improve the disparities without some of the other interventions we'll talk about shortly. You know, so many of you probably are following the presidential elections, so sorry, very interesting. And so many of you have seen this exact picture from about 3 weeks ago. So, you know, Hillary Clinton, Black Lives Matter movement, and movement advocacy. And so the story, for those of you who aren't aware, at one of her campaign events, she, after the event, behind the stage, she ended up talking for about 5 minutes to some of the leaders of the Black Lives Matter movement. And these are Hillary's words that were in the New York Times from, again, about 2 or 3 weeks ago. And this is about sort of violence against African Americans. You can get lip service from as many white people you can pack in Yankee Stadium, and a million more who like it who are going to say, we get it, we're going to be nicer, she says. That's not enough, at least in my book. She also went on to say, I don't believe you changed hearts, summarizing her basic view of social policy movements. I believe you changed laws, you changed allocation of resources, you changed the way systems operate. So personally, I think, you know, both in terms of Black Lives Matter and in terms of health disparities, there are some things that Senator Clinton has gotten wrong, some things she's gotten right. On the wrong side, I do think it's important to change hearts, that you got to have people that got to believe it, you know, and they have to be committed to do it. But at the same time, I think she raises a great point that cultural competency training, for example, is not going to be enough. You got to change the infrastructure, you got to change the system, you got to change the financing. And again, here's where CMS basically is the most powerful player in this area. So the second step of the roadmap, and, you know, Patrick Conway talked about this earlier, basically implementing a basic quality improvement infrastructure, a quality culture, quality team, goal setting, measurement, local champion, senior support, well known. This third one, though, is something that we as a nation just don't do a good job at, and that's making equity an integral part of quality improvement efforts. You see the Grand Canyon, and then you see the IOM Unequal Treatment Report and the IOM Quality Casting Report. It's meant to symbolize that too often the people who work in quality are different than the people who work on equity issues. What does this mean, though? So each year, there is this picture or a very similar one of it on the University of Chicago website. And it's the University of Chicago staff marching in the Bud Billiken Parade. The Bud Billiken Parade is the largest African American-centric parade in the country, of course, in the south side of Chicago. The point is that, well, community events are actually good things. And, so probably most everyone here has volunteered at a community event at one point or another. It's a great thing to get our kids involved in at an early stage. But if all the University of Chicago did each year was to march in the Bud Billiken Parade and then say, well, check mark, we've done our community event for the year and we've done equity work for the year, that'd be a drop in the bucket. As opposed to if everything we do with quality, a pneumonia initiative, an HIV initiative, an asthma initiative, a prenatal care initiative, we think about how can we deliver the best possible care, whether people are black or white or Asian or Hispanic, whether they're rich or the poor, you see it's much, much more powerful. So many people here are probably familiar with the IOM 6 Pillars of Quality. And typically in an audience like this, even a very knowledgeable audience like this, there's usually only 2 or 3 people that have seen this exact slide. And people just don't realize that in 2010, the IOM actually redid their model of quality, where you notice on the far left-hand side, equity was taken out as one of the 6 pillars and made into a cross-cutting dimension that cuts across all the different pillars of quality. So again, this issue of you think about equity up front. And here's where I think CMS, like a lot of others, they haven't quite done this, where the thought or the hope is that, well, you do a generic quality initiative and you spread it out across, well, ultimately you're going to improve equity. I think we found that you basically have to have equity up front. So you need to think about up front, how do you make sure that the care and the outcomes are good for everyone, no matter who they are. So something that I think a lot of us can improve upon. So step 4 is design the intervention. I'm going to talk about 2 different things, root causes and 6 levels of influence. So root causes is common sense, and it gets back to this issue of like tailoring the populations that, if you're going to figure out, why there are these disparities in foot amputations for diabetic patients, African Americans in the south side of Chicago, you basically need to talk to the patients, find out, what's going on. And so similarly, talking to an African American doctor or nurse in the south side of Chicago is no substitute for talking to patients with diabetes, African American on the south side. And too many times people make that mistake, and if there's time, I can give a story, sort of a horrible story actually, of what happened in the Medicaid program and one of our neighborhood health plans in our program that basically relied upon minority proxies as opposed to talking to patients. So here's our conceptual model for reducing disparities. Common sense model, left-hand bubble, you have a person living in their community. If they have access to care, they become a patient interacting with a provider within a healthcare organization. And above that, you have a policy superstructure. So again, like the big 800-pound, elephant or in the room really is, financing. And CMS is the most powerful player, and so what CMS does, the rest of the nation follows. So they really have the best opportunity to make a difference impacting process of care and outcomes. So I'm going to use the example of pediatric asthma, and so talking about these 6 different levels, examples of interventions or things that can be done. So for example, policy, how can policy and resource allocation can promote clean air, reduce exposure to secondhand smoke in a non-allergenic housing environment for kids? At the level of the health organization, how can you reduce ED visits and readmissions by doing things like extending hours for primary care access or same-day appointments? The microsystem is the immediate healthcare team. So for example, can office-based teams integrate community health workers to support home-based asthma management? The provider, so for example, can we train clinicians in culturally appropriated motivational interviewing to improve care? Patients and families, so for example, can parents safely use email or text messaging to handle real-time serious asthma exacerbations? And communities, so for example, can schools do screening of student athletes to try to identify kids with asthma? So, when you look at like over 400 interventions in the literature, there aren't a lot of common themes for what can reduce disparities, and here's the best we can come up with. Not surprisingly, multifactorial interventions that attack the different levers of disparities, culturally tailored approaches, again, not surprisingly better than generic approaches, team-based care, nurse-led care oftentimes, involving families, community partners, health workers, or patient navigators, interactive skills-based learning as opposed to didactic lecturing. But in some ways what it means is that, there's no magic bullet, and so what it requires is this QI approach where organizations have to be motivated to basically do the hard work of QI, to do the root cause analysis, to talk to the patients, talk to the providers, and then tailor their interventions depending upon the problems that face them. So you have to have that motivation to do that. The 5th step is basically implementation science, sort of a emerging buzzword here. And here you can think about like the different frameworks for implementation of science. So, what is the advantage of your intervention over the status quo? What are the external incentives that would lead someone to do this or not? What's the culture of your organization? What are the beliefs of individuals at your organization? What's your process for planning, executing, and evaluating? So I like this slide because it's behavior change theory on one slide, which is crucial to any of us in the equity world because, really that's the whole thing. How do you get individuals and institutions and organizations to change? So first we're taught, well, is education. If you basically change people's beliefs and knowledge, that's going to solve it. And so rapidly you realize that's not the way the world works, that it's necessary but not sufficient. We're cultures, preachers of we're captive to, in a sense, our environment, so social norms, so, peer pressure, what our neighbor does or, what is the culture or place, we're influenced by that. Environmental factors, some particular financial incentives, and then very importantly, self-efficacy. Basically, we need to have the confidence to be able to do it. So here's where coaching comes in. And there's this big issue now about intrinsic versus extrinsic motivation. So intrinsic meaning professionalism, doing the right thing because it's the right thing to do to reduce disparities. Extrinsic meaning, what are the things that, motivate us in terms of extrinsically, like financial incentives. And I think the current state of the art is that you have to do both. That incentives are going to be important, but ultimately you can only incentivize so many different things. You need to rely upon people's sense of professionalism. So the sixth step here, sustainability, so institutionalizing things so they become part of routine practice. You've all seen the societal case for disparities, the economic costs and the need for a healthy national workforce. What I want to focus on is the other type of economic incentive, which is the business case. So in other words, achieving health equity has to make sense from the perspective of the individual healthcare organization or provider, or else it won't be achieved. So December 2014, I wrote an editorial in the New England Journal of Medicine on how to achieve health equity. So I spent a lot of time on this editorial because I knew that this was an important opportunity to reach a broad audience, including a broad lay audience. So I thought hard about, well, how do you sort of synthesize the solutions to disparities into 4 different bullet points? So here they are. Look at your data. This is something CMS could require. Talking to your patients and tailoring care. So that's really interventions, what we're talking about. It's basically tailoring care to the patient. Align the incentives, which we'll talk about more in a moment, so incentivizing and reducing disparities. And one thing we haven't talked about yet, which is crucial and where really CMS plays a crucial role, assisting the safety net. The Affordable Care Act has made a lot of progress, but we still have a broken healthcare system, and the way it currently works right now, unless you assist the safety net, there's still going to be huge disparities. So it takes us full circle to, where's the business case? I start with those 2 stories about my dean and, and FQHC. Where's the business case now that would make Dean Polonsky make equity a higher priority and would make the medical director at Chicago Family take it to the next level in terms of reducing disparities, which, at least as a year ago, that, some of the incentives are here, but there's still not enough. So more broadly, what can influential groups such as CMS do to reduce disparities? So 3 buckets here. Increasing the readiness and motivation of frontline organizations and clinicians to reduce disparities, providing the skills to reduce disparities, and then third, align the incentives to reduce disparities. So specifically for CMS, there's a whole load of things CMS can do, and I put down some of them on this slide. The choice of clinical performance standards measures in terms of accountability and what equity standards are set. There can be structural requirements that for how can institutions be culturally competent, equitable health organizations. Clearly, CMS is powerful to be able to convene stakeholders, to promote a culture of equity nationwide, to provide technical assistance as they have started to do through some of their innovations programs, and to address the social determinants of health, through population health initiatives, intersectoral, meaning health and non-healthcare sectors that impact health disparities. But I'm going to spend the rest of my time really on sort of like the hammer, which is really the hammer, the carrot and the stick in some ways, align the financial incentives, which is the part which, if it's not done, the place like University of Chicago, the place like the FQACs, they'll do some work, but not enough. Aligning the financial incentives. So first, public reporting of stratified disparities data. Low-hanging fruit, something CMS can fairly easily do now. Incentives for prevention and primary care. So right now we still have a system where largely health organizations are rewarded by taking care of the complications like the diabetic foot amputation, as opposed to investing the money in primary care and prevention, keeping people out of the hospital. So global payment, shared saving programs. And then pay for reducing disparities. So I am hopeful that CMS within the next 3 years will actually have programs where it's not pay for performance, but pay for reducing disparities. and starting to think about things like rewarding relative improvement in disparities as well as absolute attainment of disparities reduction. Thinking about comparisons of different patient groups, so you have apples to apples comparisons, and comparing to similar organizations, so you have again a peer-to-peer comparison. We talked about taking care of safety net providers, and actually Patrick Conway talked a little bit about this. So it's a common, if you think he couldn't talk about what he says are impending. So it's both adequate payment for safety net providers, it's support for quality improvement. Often the time safety net providers are under-resourced, and then risk adjustment to create a level playing field. So again, full disclosure, I was on that risk adjustment NQF panel, and I'm talking just for myself now, not for the panel, not for NQF. And so the recommendation was to make sure there's risk adjustment so that that organizations that care for a particularly vulnerable population don't be punished. And so, from my understanding, this was the topic that the NQF got the highest number of comments on, over 100, of which only 7 oppose risk stratification, and one of those 7 was CMS. And I think that one of the reasons that the committee actually pushed for risk adjustment was that, at least as of that time, what CMS was doing in terms of equity in vulnerable populations just wasn't strong enough, and there just was not confidence that CMS sort of backloaded in terms of what happens with the use of risk adjustment and performance measures, at least at that time, was not doing enough to improve equity. So the need was to then have this recommendation to risk adjust for socioeconomic status. The theme here is that there will probably need to be blended payment approaches, so combination of global payment, shared savings, and potentially value-based payment, pay performance, in conjunction with QI, but both have to have an explicit equity lens. And again, here's where I think that CMS hasn't done enough of, specifically thinking up front. If our goal is equity, how do we design these programs up front so we lead to a situation where we have reduction of disparities? There are good people at CMS, and Kara James has been doing remarkable things over the past 4 years. Patrick Conway is very impressive. But as a whole, equity has not been high enough on the priority list as it needs to be. We talked about equity accounting measures and payment programs, and then the work of the CMS Innovation Center. There clearly are methodological issues that need to be grappled with. And, so small sample sizes for some groups in terms of minority populations. What are the best equity performance measures? Do you risk adjust? Do you stratify? Do you use combinations of these measures? What's the best comparison group for performance measures? What magnitude of incentives makes a difference? Who do you incentivize? For example, an individual or the group. So we now have a small Robert Johnson program that we have in University of Chicago. It's a program office that's basically trying to look at reducing health disparities through payment and delivery system reform. Small program, 3 grantees, but we're trying to have a start. In all of our grantees, they're doing some combination of delivery system reform, intervention, and some type of payment reform. There's usually some combination of pay performance, global payment, and shared savings. Small program, we have to hope to make a start. CMS has much more resources, much more potential to make a difference. So really, as I said before, they're key. I actually tell, I do a lot of talks for younger people also, and I actually tell people that, and who often idealistic young people, I tell people, this is actually the best time in my lifetime, and I now am old enough to be a card-carrying member of the WARP, but it's the best time in my lifetime to make a difference. I think the stars are aligned. But I do believe that unless CMS in particular acts, because they are the most powerful organization, if they do not act, that it would be a wasted opportunity. And I ended this editorial in the New England Journal of Medicine by saying that leadership matters. It is our professional responsibility as clinicians, as administrators, and policymakers to improve the way we deliver care to diverse patients. We can do better. Certainly I can do better. Healthcare organizations can do better. All of us here can do better. CMS can do better. And I look forward to working with you as we march forward ahead, trying to reduce healthcare disparities and reach equity. Thank you very much.
Thank you, Marshall. And our next speaker will be Kellen Baker.
Thank you, Chris. And wow, that's going to be a tough act to follow, Marshall. But my name is Kellen Baker. I'm from the Center for American Progress. And I just want to start off by acknowledging how grateful I am to be here. Marshall mentioned the convening power of CMS as one of the primary levers towards reducing disparities and achieving health equity. And it is not lost on me how important it is that LGBT disparities are part of the agenda today for two big reasons. One, because all of us who work on LGBT health disparities are deeply, deeply indebted to the movement for racial and ethnic health equity, not only in terms of the strategies that we use on a federal policy level or a state policy level or on a clinical setting, but really because it is this movement, it is all of you who have done that hard work of identifying disparities, defining health equity, and clarifying our moral duty as a country to address these disparities and achieve health equity for everyone. And so I do also just want to mention that regardless of where you are on morality issues, we know these are playing out in a big way on the public stage around LGBT populations, we are all here because we believe that health disparities are a moral failing of our nation. Everyone should have the right to be healthy, to be safe, to live in safe and healthy communities in a safe and healthy nation. And the same is true for LGBT folks. And the second reason why I'm so grateful and happy that I am here is really because we are talking about the realities of people's lives. It's not LGBT people over here and everyone else over there. People are living at the intersections of race, ethnicity, class, sexual orientation, gender and gender identity, age, all of these different factors that make up how healthy we are able to be, how safe our communities are. And our policies need to be living at those intersections too. And really, if we look at the history of, for example, the HIV epidemic in this country, it is impossible to fully eradicate the disparities that are associated with race or ethnicity or any other disparity factor without also addressing the stigmatized sexual orientation and gender identity disparities that so many people are living with today. So with that, I'm going to talk a little bit about who LGBT communities are, just to make sure we're all on the same page. I know all the kids these days are coming up with their new language. I'm not as young as I look. I'm struggling to keep up. So just to make sure we're all on the same page about some of the language I'm going to be using, LGBT stands for lesbian, gay, bisexual, and transgender. Sexual and gender minorities, you heard Chris mention, that is a synonym for LGBT. It's typically found more in the research world. It's important to know that the LGBT umbrella actually includes two distinct aspects of people's identities. The first is sexual orientation. And despite the presence of that fun little root word, sex, it's actually not really about sex. It's about who you love. It's about who you create a family with. It's about what your community structures and support look like. Some of the terms that are typically used to describe sexual orientation include heterosexual or straight. Yes, all of you who are straight, y'all have a sexual orientation. Gay or lesbian, bisexual. There are other terms as well, same gender loving, for example, in predominantly African American communities. The second big aspect of individual identity that's bound up in that LGBT umbrella is gender identity, which is each person's deeply felt internal knowledge of your own gender. So when you wake up in the morning, for most of us, we know we're a man, we know we're a woman. For some people, they may identify as a gender outside of that gender binary. That's your gender identity. And again, just like sexual orientation, all of us have one. It's just that LGBT folks usually have to spend a little bit more time thinking about sexual orientation and gender identity because, again, of the disparities that are associated with these aspects of identity. Some of the terminology around transgender folks, and I apologize for the small font on the screen, it's really a testament to all of the news that's coming out around transgender folks these days. Folks heard about the transgender tipping point? No one? Yes, thank you. Yes, the transgender tipping point, so-called. We're seeing so many more news stories and information coming out about transgender folks who are people whose gender identity, so that internal knowledge of their own gender, is different from what's typically associated with the sex that they were assigned at birth, which just means the sex that's on their original birth certificate. And I say original because it is possible in the United States, in most states, to change your birth certificate, as well as your driver's license, your passport, military ID, school records, all of these other things that we use to determine someone's legal sex and legal name. A transgender man or a trans man is someone who is assigned the female sex at birth, but identifies and lives as a man. So transgender men grew up being told they were girls. They knew they identified as boys. When they grow up, they live as men. A transgender woman is a person who is assigned the female sex at birth, the male sex at birth, meaning on her original birth certificate, but identifies and lives as a woman. Genderqueer and gender nonconforming typically refers to a person who identifies outside, again, of that binary. Some other terms you may have heard include two-spirit among predominantly Native American communities. Gender transition, that thing that the media really loves to talk about, that process that a lot of transgender people go through to change from the sex that's on their original birth certificate to the sex that they identify as, to the sex that reflects their gender identity. Gender transition is different for everybody, but it typically includes a variety of legal steps, changing some of those ID documents, and medical steps, which is one of the big reasons why it's such an important thing to talk about health and health equity, not only in the context of lesbian, gay, bisexual issues, but particularly for trans folks. Here are some examples of trans people. If you have not been consuming media lately, you may have missed them, but if you've turned on your TV or opened up a magazine, you may have seen some of these faces. Janet Mock, for example, who has a show on MSNBC. Laverne Cox, a transgender actress on the cover of Time magazine. The woman on the, I suppose, what would she be? The top right for all of you. That is my friend Regina from Colorado. Regina is a transgender woman who, before the Affordable Care Act, was on the verge of having to sell her house because she couldn't get health insurance coverage because as a transgender person, she was just locked out of coverage entirely. That meant she couldn't get coverage for her hormone therapy. She also couldn't get coverage for her asthma medications, which were actually way more expensive. When she transitioned, she lost pretty much everything. Her marriage, her children became estranged, her job. And again, she was on the verge of losing her house because of those medical bills that were mounting. Under the Affordable Care Act, she was actually able to get a plan that covers everything she needs, does not lock her out of coverage as a transgender woman, and today she actually travels around the country with me to various events talking about the difference that the Affordable Care Act has made for her. So how big of a population are we talking about here? Some people think it's like 45% of the US population is LGBT. Some people think it's practically no one. The answer is really, at least as far as we know, somewhere in between. These data are from the Gallup poll analyzed by the Williams Institute at the UCLA School of Law, and they found that more than 8 million Americans identify as gay, lesbian, or bisexual. Then, in addition, another 700,000 Americans who identify as transgender. That means there are at least 9 million LGBT Americans living all across the country today, and it's important to know that this is probably a serious undercount, because we as a society, as we know, are not to the place where it is safe for everyone to come out as lesbian, gay, bisexual, and/or transgender. So this means that there are actually probably a significantly larger number of people who would actually fall under that LGBT umbrella. 9 million LGBT Americans, population of New Jersey. Who here cares about New Jersey? Yes. There we go. So this is a sizable population we're talking about. And as I mentioned, LGBT folks live all across the country. There are no states where there are no LGBT people. No surprises that the largest populations are in the states with the biggest populations, right? California, Texas, Florida, New York. But LGBT people are everywhere. These 9 million LGBT folks also include close to 650,000 same-sex couples who identified themselves on the last census, and that number is only going to go up now that couples in every state are able to get married. And one thing that I just want to pause on before I go on to talk more about LGBT health disparities is that it is really not appropriate in a lot of ways that I am the one sitting here talking about this, because I am just some white dude and I am not actually representative of the faces of the LGBT community. If you trust the media, you'd think this is what LGBT looks like. Actually, that's what LGBT looks like. We are parents, we are communities of color, we are immigrants, we are young folks, we are old folks, we are benefiting from the Affordable Care Act. That big photo down there, those are 10 LGBT identified people who are either navigators or beneficiaries of the Affordable Care Act from 8 different states who came to meet with the Surgeon General to talk about the importance of the ACA in their communities. And the woman on the bottom there with the shiny little where to start, what to ask pamphlet, which is intended to help LGBT people in insurance enrollment, her name is Aurora. She works for the Lesbian Health Initiative of Houston. She got coverage under the Affordable Care Act, and she spends her days talking to her fellow LGBT community members about why prevention and wellness, particularly in the context of cancer, are so important for LGBT community members. So as different as we all are in the LGBT community or LGBT communities, there are a couple of trends or threads that continue to unite us as far as the common experiences that many LGBT folks have when they're trying to navigate aspects of daily life like getting health care. Some of the big factors that contribute to LGBT health disparities include anti-LGBT bias and discrimination, full stop. People treating LGBT people badly because of who they are. Racism and other forms of structural discrimination, such as sexism and the way we treat immigrants in this country. A lack of legal recognition for relationships, and actually in terms of gender identity and transgender people, being able to get an ID document that shows who you really are. That's really important for things like going to the doctor, voting, being stopped by the police, and not having it be escalated even further than it might already be. Poverty, homelessness. Up to 40% of the up to 40% of the U.S. out-of-home youth population identifies as lesbian, gay, bisexual, or transgender, or queer, or questioning. These are young folks that are kicked out of their houses, rejected by their families because of who they are. That has health impacts all the way through the rest of their lives. Lack of insurance coverage, which is something I'll talk about in a little bit more detail momentarily, and a lack of LGBT cultural competency. So just to go through a couple of these very briefly in turn, poverty. Again, the media representations of the LGBT population is that we're all wealthy white dudes living in San Francisco or wherever and have no problems. Not actually true. LGBT people are generally more likely than the US population to be living in poverty, particularly if they're LGBT people of color, particularly if they're parents, particularly if they are a female same-sex couple. Because you take two people who are dealing with sexism and making 77 cents per every man's dollar, you put them together in a family, those disparities multiply. This data is from research that the Center for American Progress did in 2014. We talked with LGBT folks across the country who had incomes under 400% of the federal poverty level, so those people who are potentially eligible for financial assistance to get coverage under the Affordable Care Act. And when we looked at the breakdown of incomes in that 0 to 400% range, as you can see, we found that it wasn't evenly distributed at all. In fact, 61% of those folks we talked to had incomes under 139% of the federal poverty level. That is just one of the reasons why Medicaid expansion is such a critical issue for LGBT communities across the country. A second big social determinant of LGBT health, discrimination. This is still happening. These are data from 2013. This is the Pew Research Center. So this isn't just me walking down the street asking my friends what kind of experiences they've had. This is nationally representative data in 2013 of the kinds of things that LGBT people are still encountering. Being treated unfairly by their employer, receiving poor service in a place of public accommodation, even being threatened or physically attacked. And this is a major problem not just for LGBT people generally, but the birth of the modern LGBT rights movement, if you will, is typically held to be the Stonewall riots in 1969, almost 50 years ago. Those folks who rioted at the Stonewall Inn launched a national movement for recognition of who LGBT people are and the rights that we need to have. Those folks are baby boomers. They are booming right into Medicare. They are booming right into long-term care, and a lot of them are encountering discrimination such as being forced to hide who they are. Maybe they've been out for years, they go into a long-term care setting, and it's no longer safe for them to have a partner or a girlfriend or a boyfriend visit. It's no longer possible for them to live as an openly transgender person. There are some protections in the PACE program, for example, has non-discrimination protections on the basis of sexual orientation. but there is still no comprehensive set of non-discrimination protections that will make sure that as LGBT folks age, that they are not actually losing everything that they have fought for decades to secure. In terms of trying to get health care, this is data from a study, unfortunately but appropriately, called When Healthcare Isn't Caring. This is a nationally representative study of almost 5,000 LGBT people and people living with HIV. Almost 8% of people being refused health care they needed on the basis of their sexual orientation. 26.7%, more than a quarter of transgender people just being turned away in a doctor's office because we don't treat people like you. Healthcare professionals refusing to touch people or using excessive precautions, using harsh or abusive language. More than 20% of transgender people report encountering harsh or abusive language from a healthcare provider. And even almost 8% of transgender people encountering healthcare professionals who are physically rough or abusive. These are the realities of LGBT people's lives today. And finally, of course, on insurance. Across the board, this is across all income ranges, LGBT people significantly more likely than the general population to be uninsured. This is from the middle of 2013 to the middle of 2014. You can see the decline. Thanks, Affordable Care Act. Woo! But still, LGBT people being more likely to be uninsured, and that's particularly true for those folks from 0 to 400% of the federal poverty level. In 2013, more than 1 in 3, 34%, were uninsured. By 2014, that number had dropped a lot to 26%, but that still means that in 2014, more than 1 in 4 LGBT people who could get financial help to get covered still didn't have insurance. All of these factors contribute to these health disparities: tobacco and other substance use, higher rates, particularly among gay and bisexual men, up to twice as likely as the general population to use tobacco and other substances. Mental health concerns, such as depression and suicidal ideation. According to Injustice at Every Turn, which is a study on the transgender population, 41% of transgender people have attempted suicide, at least once. That's a rate 26 times higher than the general population. Higher rates of certain cancers, such as breast cancer among lesbian and bisexual women, compounded by the fact that it's harder for them to get access to preventive screenings because they're less likely to have insurance. Higher rates of HIV and other sexually transmitted infections. The HIV epidemic isn't over for anybody. It's really not over for LGBT folks, particularly gay and bisexual men, particularly gay and bisexual men of color. Gay and bisexual men, about 2 to 3% of the US population, 65% of new HIV infections, 55% of new AIDS diagnoses, and 45% of the deaths from AIDS since the epidemic began more than 30 years ago. And in 2008 to 2010, this is just some of the most recent data that's available, HIV among young Black, gay and bisexual men and other men who have sex with men increased 20% in 2 years. And higher rates of experiences of bullying, violence, and abuse, particularly transgender people. Right here in the Baltimore and DC metro area is an extremely dangerous place for transgender women, particularly transgender women of color. There have been 20 transgender women murdered already this year. Several of them right here, Baltimore, DC, predominantly women of color. Backwards, forwards. So fortunately, that's like depressing. I'm sorry, I'm going up, I promise. There's a lot that's happening, and I know I have to wrap up my time too. There's a lot that's happening on the federal policy level that is actually helping us get a handle on some of these disparities and address them. These are just some of the many things that have happened. Healthy People, for example, Healthy People 2020 has a new LGBT health topic area that talks explicitly about discrimination, oppression, and stigma in driving health disparities among LGBT folks. 2 Institute of Medicine reports, one in 2011 on general LGBT health disparities, and one in 2012 on collecting sexual orientation and gender identity data in clinical settings. The Joint Commission, ARC, SAMHSA, the Office of Minority Health, the Culturally and Linguistically Appropriate Services Standards, the class standards, woo, love the class standards. Really? Come on, Mara Udelman, you clap, there we go. they actually include sexual orientation and gender identity in that blueprint, the implementation blueprint, as some of the factors that need to be looked at when you're providing culturally and linguistically appropriate services. And of course, the Affordable Care Act. So 4 priority health topic areas, LGBT health topic areas that I'm going to talk about briefly, starting off with data collection. Because if everyone noticed, one of the primary things that Marshall mentioned when he was talking about interventions, it all started with data. Well, guess what? We don't really have the data that we need to actually talk about where do we need to go with LGBT health disparities. We know they exist, we know how bad they are, but we don't have the data we need to actually really get a handle on fixing things. So there are 4 main places, or spheres of LGBT data collection, if you will: research, population surveys, administrative and program data, such as the health insurance marketplace application, and clinical records, especially electronic health records. None of these areas of data collection currently collect sufficient data, actually currently really collect any data at all about sexual orientation and gender identity. That needs to change. These are just some of the aspects of LGBT identity that are wrapped up in this universe of LGBT data. Identity, attraction, and behavior. Your relationship status, that's actually a data point related to sexual orientation. Transgender status, your current gender identity, as distinct from the sex that you were assigned at birth, and preferred name and pronoun. Second, and actually I should say my slides will also be available, so please feel free to take this home as a blueprint for implementation, collecting more and better data on LGBT populations. ACA implementation, Medicaid and marketplace enrollment in particular, non-discrimination in health coverage and care. Kara mentioned earlier the Section 1557 regs that include gender identity and sex stereotyping. We need those to be adopted in the final rule, and we need that final rule to make sure that it mentions sexual orientation, because as we saw, people are still encountering all of these barriers to coverage and care. Trans-inclusive coverage in public and private coverage programs. Actually, one of the biggest steps here was made by the Medicare program last year. They lifted the transgender-specific exclusion that had prevented transgender people from getting coverage for gender transition under Medicare, and a lot of other insurance programs are starting to follow. And coverage to care for marginalized patient populations, particularly LGBT folks of color. So this is just an initiative that I run out of CAP, Out to Enroll. You should please feel free to visit us, outtoenroll.org. We will be at the U.S. Conference on AIDS on Thursday talking about LGBT outreach strategies among communities of color, in particular for reducing HIV disparities. Public health policies, funding, and programs, all of the different policies and programs at HHS, at state health departments across the country, recognition that LGBT is a health disparity population and an underserved population. The Office of Minority Health at HHS has a number of great publications about that. HIV prevention and treatment, population-specific issues. I mentioned some of the things that are facing LGBT elders as they age into long-term care settings. And cultural competency requirements tied to program funding. It really should not be permissible in the year 2015 for service providers to be able to choose whether or not they're going to treat LGBT people like human beings. And finally, medical education. For you doctors out there, think back. There's an average of only 5 hours of LGBT content in medical education. The majority of that is on HIV and AIDS among gay men. Clinicians talk to me a lot about a lack of both cultural and clinical competency in LGBT health. And in particular, there's a real lack of knowledge around transgender health in particular. So fortunately, there are some steps forward to rectify that. The AAMC, for example, published these guidelines in 2014, implementing curricular and institutional climate changes to improve healthcare for individuals who are LGBT, gender nonconforming, or born with DSD, which is disorders of sex development, which is a more medicalized term for intersex. So the takeaway, marriage equality happened. This is very exciting for a lot of LGBT folks, but we cannot forget that so many other faces of our community who are still having trouble getting coverage, still having trouble getting care, who really need all of the kinds of innovations and advances that you are all committed to and that we are talking about here today. So thank you.
Thanks, Kellen. And I keep thinking back to Kara's original slide, which is the journey of 1,000 miles begins with a single step. And there's just been so much food for thought for us at CMS and hopefully for all of you as we go forward. And now I want to introduce our final speaker of the morning. I guess it's afternoon by now, Dr. Gloria Cron. We have a tendency at CMS to always think about the disabled or refer to the disabled, and that's people whose reason for entitlement to the program is that they've been adjudicated by the Social Security Administration as being disabled. But we definitely know that the disabled population includes a far greater number of people than just those who have been determined eligible for the program based on disability. And I'll turn it over to Gloria.
Great, thank you. And like Marshall and Kellen, I really am so pleased to be here today. There are at least 50 million Americans in this country and their families who are really grateful that CMS is taking on these new 59 million Americans and their families who are pleased that CMS is taking on these new populations. I'm going to start with a very quick description of who are people with disabilities, what's their current state of health disparities, where should we, CMS, be going, and then some very specific ideas about how we can get there. Much of what I'm going to be presenting was pulled together as part of a cross-agency HHS task force when I was still working at the Centers for Disease Control and Prevention, and came out earlier this year in a paper that was co-authored with Deborah Klein-Walker and Rosalie Correa de Araujo. So many of the references refer to that. Here we go. All right. I want to start, though, by telling a story. And it's, I come from a large family, and my sister, who was just older than me, had, and she was my protector growing up, had MS, multiple sclerosis, as a diagnosis at age 40. And unfortunately for my sister Edith, her MS has been progressive and very aggressive. And when I go back and catch up with her periodically, there was a time when we were sitting on her porch, and she has moved into a fully accessible house with her husband. She's had to give up teaching, which she loved, and she's telling me that she's no longer driving because her vision and her reflexes aren't good enough. And then she says in her slurred speech, "But at least I'm not disabled." And that, I think, spoke both to her optimism, but also to the stigma and the confusion about what disability means. I hope by the time this morning is over, we'll all be appreciating that just disability is just a normal part of the human experience. So who are people with disabilities? They include a young girl born with spina bifida who will live her life with limitations. It's young adults who acquire limitations because of illness, or a military vet because of an injury. It's people because of chronic diseases like diabetes that lose their vision or may need amputation. And it's people who, as they get older, increase in frailty or hearing loss or dementia, and because of that need additional supports or services. People with disabilities are a very diverse group of people. What they share is that they all experience a serious limitation in functioning, and that limitation often leads to exclusion from their communities and from their healthcare system. And I'll argue that it unnecessarily leads to poorer health. So why is disability a new health disparity population? I think there are probably at least 3 reasons from my perspective. One is that up until the mid-1950s or 60s, in this country, if you had a significant disability, chances were very good that you would live your life in an institution. And then beginning in the 1960s, there was this deinstitutionalization movement that led to many people being placed back into their communities, and people who were subsequently born with a disability or acquired a disability did not go to institutions. So we saw this growing visibility and presence of disability in our communities. The second, I think, is expectations. We have seen a dramatic shift in what we expect for the health and the lives of people with disabilities in my lifetime. We've seen a shift in attitude from really being a throwaway population to being a population that was patronized, and we would do this because it was the right thing to do, to now being a population that should enjoy the full rights and responsibilities of all Americans in this country. That's really a fairly recent change. And then finally, the disability community finally is getting some good data. And I'll be presenting some of that, perhaps too much, you might say. But I want you to recognize that 13 to 15% of people in this country and globally report significant functional limitations. And in the US alone, we spend $400 billion, $400 billion on disability-related health costs, 70% of which is paid by public dollars. So we've got a lot of money on the table. We've got a lot of reasons to get this right. Well, because we're lauding the AC, I didn't know that was going to be the focus for today, but we are. This community has really valued from that. Prior to 2011, we had multiple different definitions, 67 federal definitions of disability. In October of 2011, then Secretary Sebelius announced the new standards, and for disability, it essentially is these questions. Do you have serious difficulty with hearing, seeing, concentrating, remembering, or making decisions, serious difficulty with mobility, or do you have difficulty with self-care or essentially transactions in your community? So these are all indications of difficulty with functional limitation, breaking it out by the nature of that disability. And then the last two questions are sometimes regarded as severity questions. This approach to disability has really been codified by the World Health Organization in this classic framework. It's called the International Classification of Functioning, Disability, and Health. And those middle boxes really indicate that you've got some limitation in your body function and structure, in your activities, or your participation in your community. It's related to a health condition, and that it's influenced by environmental factors and other personal factors. As I said, we're getting much better information and understanding at a population level of who experiences these disabilities and the nature of those disabilities. So this graphic shows the proportion of adults who report a disability within age categories, and then the proportion of the total population of that particular age category. So don't know if I have a pointer in here, but if you look at the far left, you'll see that among young adults, only 6% report having a serious disability, whereas by the time we're at the other end of this spectrum, in 85 plus, it's fully 2/3 of people report significant limitation. What's important to note, however, is that more than half of people with disabilities are under age 65. And significantly, a full third of those are between the ages of 45 and 64, really prime working years. So what are the kinds of limitations if you report a disability? 46% of people report it's walking or mobility, 39% that it's problem solving, that concentrating, remembering, or solving problems, 26% report hearing, 21% report difficulty seeing even if they have glasses, and then 35% require some assistance either with activities of daily living or instrumental activities of daily living. Now this adds up to more than 100%, those of you who are quick with math, and that's because more than 40% of people will report more than one serious limitation. People with disabilities are also large healthcare users, or at least some of them are. This is a slide of a paper that's coming out shortly by a colleague, Amanda Riekert, and her co-authors, and they're interested in looking at chronic conditions. So the large circle in this graphic represents all people who are of working age. The pink circle represents those who report at least one chronic health condition. The blue circle is people with disabilities, and you'll see there's significant overlap between people with disabilities and those who are reporting at least one chronic health condition. And then the tan or the yellowish circle is people who are high healthcare utilizers. So it's starting to help us understand better how these populations overlap and whom it is that we're really working with and talking about. And it's that intersect. There's about 9% of the overall working age population that reports all three. And significantly from a disability perspective, those are people who are also reporting that they need help in care of daily care or in transactions with their community. So that's some of who people with disabilities are. What's the current state of health disparities among these people? Well, it's said most clearly by looking at what's the likelihood that people will report when they're asked, how good is your health? Is it excellent, very good, good, fair, or poor? Very common question. That 44.3% of people with a disability will report fair or poor health. That compares with less than 10% of people without disabilities, 4 times the likelihood to report poor health. And that finding holds across the different race ethnicity groups. So that disparity between with and without disability reporting fair or poor health holds across the different race ethnic groups. What this slide also shows is that there's difference across those race ethnic groups between people both with and without disabilities reporting poor health. If we look at this geographically, those people who report having a disability and having fair or poor health, the majority of them really bulk up in the southeast quadrant. Not surprising, given other work that you know, but it's always confirming to see that what we thought was going on was probably going on. So our task now, disabilities is a little bit tricky because the condition that created the disability could also be creating poor health. But our task then becomes to understand what's preventable in the poor health outcomes, and then what can we do collectively to improve health. So my coworkers and I, in looking at working to understand health disparities of this population, reviewed a lot of the existing research and the nationally represented data. We focused on the Healthy People 2020 data warehouse and the data indicators in that, because those data sources have already been vetted for credibility and for national representativeness. And importantly, because poor health, as I said, can lead to disability, we focused on those indicators where we could expect equivalence across people with and without disabilities. And then we conducted some original analyses on healthcare access, health behaviors, social determinants of health, and health outcomes. And that's what I'll show you now. If we look at disparities in healthcare access, if I have a disability, I am 2.5 times more likely to report that in the past year I didn't get health care or I delayed it because of cost. If we look at clinical preventive services, we also see some differences. Those differences aren't so dramatic unless you've been involved with a group or a task force who has worked to try to inch those up even by a percentage point or 2, and then suddenly you start to say, yeah, you know, a 7-point difference across populations is important. We need to pay attention. If we look at health disparities, adults with disabilities are up to twice as likely to report poorer health behaviors, such as not engaging in leisure time physical activity, of greater likelihood of being measured as being obese, and we see that in children with disabilities as well as adults, suggesting it's not the obesity leading to the disability. And we see much higher rates of smoking. And that again applies to people who are younger, where we don't think that it's the smoking that led to the disability. That issue of causality comes up frequently on this particular topic, and there is now good and increasing research that really supports that the disability occurs before many of these unhealthy behaviors. So other factors that we know that contribute to poor health are also more pronounced for people with disabilities. They're more likely to be unemployed even if they're able to work, and overall much more likely to be unemployed. They're more likely to have dropped out of high school. They're much less likely to have access to the internet. Oops, I'm sorry, that didn't move forward. There we go, sorry about that. They're much less likely to have access to the internet. They're almost twice as likely, or more than twice as likely, to live in poverty and to say that transportation is a major problem for them in their lives. It's this whole combination of social determinants of health, of access to health care, and access to opportunities to engage in healthier behavior that has been called the cascade of disparities for people with disabilities. So it's not surprising that we see some major differences in health outcomes, but let me point out several that were surprising even to me. That if I have a disability, the rate of being newly diagnosed with a case of diabetes is more than 3 times higher than if I do not have a disability. That's 19.1 per 100,000 persons, per 1,000 persons rather, compared with 6.8. That we see 3 to 4 times the rates of cardiovascular disease in this population. And importantly, that difference is also noted among younger people with disabilities. You're 50% more likely to be a victim of violent crime, and you are less likely to report feeling that you have adequate emotional and social support. So that's, in essence, the health disparities that we're looking at now. Where should we, in particular CMS, be going? I've worked with a number of the other major reports that have come out, and we've had some excellent reports in the past 15 years. In summarizing those recommendations, those were then carried forward within HHS. We then negotiated. We were told we could have 4. We went up to 5 recommendations. And then for this presentation, I also reached out to a number of disability organizations and researchers. The disability community is in need of really helping to centralize what their core messages and asks will be. So I'm hoping that this will help us serve as a framework for that. I've summarized these recommendations as 5 under the acronym, not terribly clever, but it was the best I could do, under WISED: workforce, inclusion, services, emergency preparedness, and data. And how can we get there? And I've got some very specific ideas for CMS in each of these different categories. In terms of workforce, every major report addressing the poor health of people with disabilities has called for improvements to the training of healthcare providers about adults with disabilities. Every one. We have recommended a 3-tiered approach, and one would be workshops, very specific workshops for very specific skills. That would be like training mammography technicians how to get a good read on a person, man or woman, who's in a wheelchair. The second would be basic disability competency training, very similar to what we've been hearing from Marshall and Kellen, thank you, earlier. And it was called for by Section 5307 of the Affordable Care Act. And then I don't think this country is going to get where it needs to go without having leadership competency training and really an infrastructure that supports leaders training around healthcare of adults with disabilities that addresses the full lifespan. I'm also aware from some colleagues in the room that the Health Equity and Accountability Act of 2014 established a national working group on workforce diversity, and that group is expected to have a report coming out shortly. The challenge for CMS and the opportunity for CMS is really to partner, in this case probably HRSA, to develop a highly competent workforce that's capable of addressing the health needs of people with disabilities. There is a program like that. It's called the Leadership Education for Neurodevelopmental and Related Disabilities for Children. And it has revolutionized healthcare provision for children in this country. We need something similar for adults, and that program or something like it could be leveraged in order to do just that. The second major recommendation relates to inclusion. People with disabilities are often excluded from mainstream programs, public health, and research activities. Sometimes that's deliberate, but often it's unintentional. So at the very least, we're calling for people with disabilities to be explicitly included and to have concerted federal effort across agencies for the explicit inclusion and monitoring of disability inclusion. That means active outreach to reach people with disabilities when you're launching new programs. It means routinely planning to accommodate for visual, hearing, mobility, or problem-solving limitations. And I would say it has got to include measuring. If we're not measuring what it is we're doing, and if we're not measuring whether people with disabilities are being included, chances are they will not be included. Now, inclusion itself is not going to be everything that's needed, and CMS is more aware than many that special programs may be necessary and will be necessary in places, but inclusion will go a long way. Services, as I said, people with disabilities, or at least some, are heavy healthcare users. At least some are getting lots of care, but it may not be the right care at the right time in the right amount. And a really key example of that is management of chronic conditions like diabetes, hypertension, and asthma. These are all ambulatory sensitive conditions, but there's growing research coming out that they are not managed well if you already have a disability. A second issue relates to accessibility of healthcare facilities and equipment. A recent study conducted in California that was across an entire health system found that, and this is 20 years, 25 years after the Americans with Disabilities Act, which would make this illegal, that less than half of the primary care facilities were fully architecturally accessible. And only 8% had accessible examination tables that would make it easier for somebody to transfer from a chair to a table. And less than 4% had accessible weight scales. We need to do better, and we can do better. So my specific challenge to CMS here would be make accessibility of facilities and equipment a quality care requirement for reimbursement. And then I know that you are attentive to the behavioral and mental health needs of people broadly, whether mental health is a primary disabling condition or whether it's secondary to a different disabling condition, but the integration of services will and continues to need attention and support. In terms of emergency preparedness, we had some very tragic lessons that we learned post-Hurricane Katrina and then other more recent disasters. At a minimum, we need coordinated planning across HHS that would call for routine training for all hazards planning, for first responders on disabilities, and then specifically for people with disabilities and their assistants. Both CDC and FEMA currently do have special populations that they target. CDC funds a network of 18 state offices on disability and health that are tending to emergency preparedness. But the efforts required to get some of that coordination happening requires everybody's participation on this. A specific challenge for CMS could be to coordinate with the Office of the National Coordinator for Health Information in order to support disability identifiers being included in data systems so that when an emergency like Katrina would happen again and people are evacuated out of state, they have much more rapid reinstatement of their benefits, ability to access medical and medication histories, and their assistive technologies. And then finally, data. We've all talked about it. We know that data drives policy and practice. HHS took a huge step in establishing a common metric for assessing disability status across surveys and programs. Let's use it. Put the disability identifier in your programs, in your surveys. Put them in your data sets. It's not going to be the same as you use for disability determination for eligibility of services, but it will allow you to cross-talk across many other different data sets in order to understand what are the issues that you're dealing with and who is the population that you're working with. We know that the standards that I did just highlight and am so pleased to be announcing do not differentiate intellectual and developmental disabilities from behavioral and mental health difficulties. That's a challenge for many groups, and for programs and interventions, it may mean some work into the future. A second key area is to routinely analyze your data by disability status. If you know that 30% of smokers are people with disabilities, then you'd better adjust your approaches to your smoking cessation programs in order to include that population. And then finally, disability research has and continues to be underfunded, but CMS would have the opportunity to really fund some excellent health services administration data as well as training opportunities, and partner with other agencies in order to coordinate research. So in summary, people with disabilities are very diverse in age, race, ethnicity, sexual gender orientation, and limitations, but they do experience functional limitations and inclusion. They also experience preventable health disparities. There are ways that we can work, and all of us can play a role in reducing health disparities. So I want to thank you all for the work that you do every day and the work that you will be doing into the future. Thank you.
I told you this would be the best session you came to all day. Now we have about 10 minutes or so for questions. We could do this two ways. There are mics down the center of the room, so if you'd like to queue up behind the mics, that would be great. We also have microphone runners, I believe, somewhere. We will. If you don't want to come up to the microphone and you'd like someone to bring a mic to you, just raise your hand. I'll keep us here for 10 minutes, so. Here we
Yeah, this question is for Dr. Chin. My name is Michael Cook. I'm a healthcare attorney and also sit on the DMAS board in Virginia. Wanted to know what you, how important is it to try and find at least a payment methodology, if not an actual payment itself, that is all payer in some form or fashion? Because it seems to me that watching the cross-subsidization, not just of payments, but also of methodology, so that you have conflicting incentives, really becomes a problem and has become a problem for clients of mine over the years.
You know, we have a pluralistic society, and there are historical reasons why we have things the way they are in this country. But I do think that there probably are a number of different solutions which could work for reducing disparities in terms of payment reform. You mentioned all payer as one possibility. I think that the keys that are necessary are, first, to explicitly incentivize reduction of disparities, explicitly. It can't be this Adam Smith and invisible hand things where things trickle down. That it has to be an explicit priority. There needs to be the shifting of emphasis to prevention, as opposed to the big bucks coming from benefiting from the complications when it's too late. Right now, it seems that probably of the things that CMS is doing, some combination of like the pay performance explicit measures, plus then some of the global payment shaved savings plans, probably are realistic ways to upfront then the prevention, addressing the social determinants of health, and also making reduction of disparities a high enough priority that the CEOs and the clinicians and the health organizations of the world spend more time on working on the quality improvement to reach that equity.
Hi, thank you. This has been a wonderful panel, as promised. My name is Rose Blackburn, and I'm Executive Medical Director at PPD, which is a clinical research organization. I'm also an officer in the National Medical Association. And my question is for Dr. Chin, as well as the other panelists. Your comment about making the business case really resonated, because I often and have consistently been trying to do that in pharma in terms of making the business case to address disparities and diversity in clinical trial research. And I was wondering if you could give a little bit more detail about some other ways to make the business case to address that, because I think that does resound not only in health plans and payers, but also in the medical device and pharmaceutical companies who develop all of the drugs that CMS and the other entities pay for.
Well, thank you for the question. You remember that slide I had about motivation, intrinsic and extrinsic motivation? So both have to be there. That can't just be financial incentives, because you can't incentivize everything. So it does rely upon professionalism. And for example, CMS saying, well, culture of equity is sort of priority. It's something that everyone can do. But at the same time, whenever I talk and work with frontline organizations, even the most well-meaning, they will say at a certain point we can't do more because we're busy, we have other competing demands, and so that unless the financial model makes it a high enough part of a priority that is part of our strategic plan, and we will then redirect the resources and do, like, in some ways, like, it's all implementation science in some ways, and so that to make it so it's worth the effort to create the culture of equity at your organization, to redirect QI so it really is tailored and, you know, individualistic, and the root cause analysis there, and it's all part of financial models. Until that's there, then it's not going to happen. And so that, you know, there's that list of things I had on a slide for CMS, the things to think about. Some of them which are financial, some of them are not. Some of them are low-hanging fruit, like the stratified performance data, and some of which are more complicated. But the financial part has to be there, you know. And in some ways, like, you know, CMS has bright people, and I would bet that most, if not everything I said today, people at CMS have thought of. I think it's an issue of priorities. You know, people at CMS are busy. I mean, they're working on important issues, but the equity part has to be higher priority, because otherwise people aren't going to, you know, address it.
Any other?
One thing that I would add from the perspective of LGBT is that we're really still in an era around sexual orientation and gender identity where it's considered perfectly reasonable to treat people in incredibly bad. I mean, this is not just something that happens to LGBT people, but I think we're all familiar with a lot of the ways that overt discrimination has gone underground for a lot of communities. There are ways in which it is called out, not enough, racism, not enough, sexism, not enough. But still around sexual orientation and gender identity, we're still in a sort of very new era around sort of the legal requirements that are related to the experiences that people are having. So you can still have people walking into a hospital, a same-sex couple, one person's in there she's collapsed with a brain aneurysm. Her wife and their children are not allowed to see her while she's dying because they are in a, quote, anti-gay hospital in an anti-gay state. So there is, I think, a lot to be said for the risk management side of things and legal compliance side of things. That is, again, not to say that discrimination does not affect so many communities and is really entrenched, particularly around communities of color. But I think with regard to the legal requirements around sexual orientation and gender identity, they are changing very fast. And so I think it behooves, from a, again, a risk management perspective and a legal compliance perspective, for hospitals and other healthcare organizations to really be looking at the potential that there could be new claims that there would not have been able to have, that would not have been able to move forward 5 or even 1 or 2 or 3 years ago.
And I think I would add to that, not only from the disability perspective, but from an Oregon perspective, where we have been moving forward with coordinated care organizations, which are the ACO versions. This new emphasis on population health and community health is really transforming how people think about what it is that they do within a clinic, within a healthcare system. So I think that's going to help drive, and again, it goes back to, and if you know that X% of this group has a functional limitations, that means they're not going to profit from the treatment that you're doing unless you make some modifications to that. It's going to make a difference. There have been a couple of good studies, one in particular that came out of Canada, Manitoba, that has a lovely integrated data system, so population-based data, that showed that people with intellectual disabilities were much more likely to be hospitalized for ambulatory care-sensitive conditions, and I think the examples were maybe asthma and diabetes. But we know that hospitalization is very expensive, and we know it's very disruptive to people's lives. If we can do something that's working better, not to get there, it's going to help make that business case.
Thank you.
Yeah, and actually, something that we are doing regarding the business case within the CMS Office of Minority Health is we've just finished up about a year of formative research, taking a look at what information do healthcare organizations need, do people who are doing health equity in the trenches need to take their boards of directors to convince them to make an investment in health equity, and that's what we're thinking about it as, an investment in health equity. And so we have basically a plan that's going to roll out over the next 4 years, where we're going to do things like provide toolkits for individuals that demonstrate, highlight best practices on how to make that business case. We're also going to be developing some economic models based on real data that we will make available to individual organizations so that you will be able to plug your data into these models and to demonstrate what the return on investment means, what it means that what does health equity mean for your specific organization. We have a few other things planned as well. Dr. Nicole Hewitt, who is on our team here, who may not be in the room but is around, is the person who's leading that project. So if you want a little bit more information about our business case project, get hold of Nicole.
Thank you so much.
Hello, I'm Darrell Means from the Seattle Regional Office, and I want to thank you all for being here. Dr. Chen, I certainly appreciate your candor. today in identifying some of the things that providers need to do. Kellen, the only thing I could say is you and I hopefully can connect after this. I'd like that very much. And Gloria, thank you for what you're doing with disabilities. Now to my question, being a veteran myself, I'm curious as to how all of you identify with veterans that have disabilities. Oftentimes veterans are seen as being inside the VA system. However, a lot of them tend to still work like myself and have private insurance. So what are some of the challenges maybe that you encounter with veterans, and how do you identify with that?
Let me take a first pass at that. And thank you very much for asking that question. Veterans are a group that, from my experience, might prefer not to be called disabled vets, but instead prefer wounded warriors or some other term, not unlike my sister, I think, who thinks, except not that word. When I was at CDC, we did reach out to work with vet organizations and worked really well with wounded warriors through amputation issues. It's not always the easiest system, from my experience, to collaborate with, but I definitely think that there are opportunities both with people who have been in the veteran system for a long time, as well as newer people. So I'm now back on a university campus. I'm delighted to be working with some people trying to get some things on our campus for returning vets who do have disabilities and who can serve as role models for some of our younger folks who did not have the military experience but also experienced disability.
And military service and veteran status is a big issue for LGBT communities, both from the perspective of sexual orientation. Obviously, don't ask, don't tell. The policy was rescinded several years ago, and we have seen a very significant identification of lesbian, gay, or bisexual folks among the veteran population and among currently serving troops, and in particular among women of color are disproportionately likely to identify as lesbians serving in the military. So keeping an eye on what the military health service is doing as far as the information that is available, particularly around mental health and the stressors that we know people are encountering. And then coming out with regard to the VA, the Veterans Administration is one of the largest providers in the world of HIV/AIDS care, of mental health services, and actually of care related to gender transition. The population of transgender people in the veterans population is estimated to be about 5 times as high as the general population. So there's a lot that remains to be done, particularly as the Pentagon moves towards making it possible for transgender people to serve openly, as is now possible for gay, lesbian, and bisexual service members. There is likely to be a significant pent-up demand in the VA system for services related to gender transition. And I think there are a lot of concerns related to pipeline, about the pipeline of providers who have experience in working with transgender populations around issues related to transition. So a lot to keep an eye on, I suppose, over the next couple of years.
I think the VA is an excellent example of what the positive things can happen when there's a culture of thinking about delivering outstanding care to priority populations and thinking in a systems way. I mean, like some of in the private sector integrated healthcare systems. I mean, the VA has some of the model programs for care management, care coordination, integration of care. So it shows the importance of culture, where if that's the culture and that's what there's this openness to that type of population type of planning and organization, how many good things can happen.
Yeah, and we also have a very good, the CMS Office of Minority Health has a very good collaborative relationship with the VA Office of Health Equity, and some of those individuals may be here today. So if you, I'm not sure where they are, if they're here, they were supposed to come, but if you have more questions about kind of the VA Office of Health Equity, if someone here is here from there, if you'd like to connect with Daryl during lunch, that would be great.
Thank you.
So we'll go to the back microphone first.
Oh. Hi, my name is Bernadette, and I'm from Chase Braxton. I am the community outreach counselor for a newly implemented program at Chase Braxton for LGBT older adults and their caregivers. And Kellen, this message is for you. As the community outreach coordinator, And because of the health disparities in the LGBT community, I was just wondering, do you have any suggestions for myself as to how I can go out into the community and to reach LGBT older adults and bring them into our program?
Thank you for that question. And it really is, I think, number one, starting with being willing to talk about it, because I think us LGBT health advocates have kind of seeded the ground that health isn't sexy. It isn't something that LGBT folks want to talk about. But we've gone to LGBT pride events, for example, with a booth about Affordable Care Act, new health insurance options, and we were totally overwhelmed with people who wanted to talk about what the Affordable Care Act might mean for them. Mm-hmm. So talking about health as an LGBT equality issue, because just as LGBT health needs to be a part of health equity, the LGBT equality movement, I think, needs to do a better job, all of us, of recognizing where health fits in, why the social determinants of health, like employment, like race issues, like people not being able to get access to jobs that provide them health insurance coverage, that those things are something that we're willing to talk about in front of an LGBT audience. And I think actually with regard to older folks, that is likely an easier conversation to have, just because, you know, I feel like from my peers, I'm in my mid-30s, and a lot of my peers don't want to talk about healthcare. They don't want to talk about health insurance coverage because that implies that they're going to need something. That implies that they're going to age. That implies that they might get sick. And that's not something that is very easy to get people, again, to focus on. And so with an older population, you have that opportunity to talk to people about what it actually might mean for them if they're unable to take care of themselves, if they're not able to live in the community, if they do become disabled, what is going to happen to them around issues of sexual orientation and gender identity. I think that's very real. A lot of people are starting to really recognize, oh gosh, you know, I could actually be forced back into the closet when I age. Right. And so SAGE, Services and Advocacy for GLBT Elders, a very robust organization, obviously with a lot of great chapters nationwide. And so I think that they are a very good partner that you're likely already working with.
Yes.
But really going out into the community and being willing, again, to talk about health, because I think it's sexy. I hope we all think it's sexy. And we just need to, you know, be, I think, even more consistent every day in all of our conversations about underlining that and helping people recognize the ways in which the fight for LGBT equality is a fight for our health, for our well-being.
Okay.
So we have a project right now where we're trying to improve shared decision-making between clinicians and LGBTQ racial and ethnic minorities, of which one of the subgroups is older adults. And one thing we've been finding in our early work is that especially when we start looking at the intersectional issues, which we've talked a little bit about, you know, like race, ethnicity, sexual orientation, gender identity, socioeconomic status. We start getting to like a lot of subgroups. There's often not a lot of experience in terms of like the best ways to go about then interacting with, you know, the Hmong, LGBT, you know, racial ethnic minority community. And so that, you know, there's no substitute for then like just getting out there and then talking to the people involved. You know, we've been working with both LGBT experience organizations as well as general organizations that aren't necessarily LGBT specific, but, you know, care for a broader group of folks. And, you know, it's really, I think, again, as you start getting more specialized, your patient population, really hard to find people that you know, really are the experts in a given area. And our experience too has been that people love to tell their stories. Like LGBT population, LGBT racial ethnic minority population in particular, oftentimes have been asked to tell their stories. And so I think if you approach things with, you know, you have the right intentions and you approach with humility of like, you know, we don't necessarily know what the best ways are going to be to work with you, but we're all ears and we want to, you know, collaborate both with you as the clients as well as the relevant organizations, including yours, then I think that's, you know, you'll go far.
Okay.
Great. We have time for two more questions. We've got one over here, and then we'll take right here.
Thank you. My name is Tomas Leon. I'm the president and CEO for the Institute for Diversity in Health Management, an affiliate of the American Hospital Association. Thank you, by the way, very timely, informative, and engaging presentation. My question, can you hear me? All right. My question for you is, you know, I know we're making recommendations to CMS, but there's a lot of national efforts going on in terms of disparity elimination and health equity. We're leading a national effort, a hashtag 123 4Equity campaign to eliminate health disparities, along with a lot of other partners. However, national conversations I'm having there's a lot of isolated efforts going on. My question is, what recommendations do you have to bring together a broader coalition or a partnership across the country collectively so we can have a collective impact in healthcare across the country?
I think the answer to that question will be found this afternoon. So when Dr. James and Jean Moody Williams will present on quality, the equalizer, and you'll hear a lot more about what's planned specifically in some of the areas that you've talked about. So I think just stay tuned.
Well, I'll take one crack at it first. So, I think like in this area, and like people in this room, and one of the great things about working in this area is there's just so many well-intentioned, people are doing it for the right reasons that are mission-driven. And so, as it is right now, I mean, like for doing things like convening folks and raising awareness and some of the educational efforts, cultural competency, there's a lot of great things happening, and I think we can go pretty far with that. However, I think that to have the real change, the money has to be on the table. And that's when people and the power drivers and the people that may not be the disciples like all of us become involved. And so that's why CMS is so important, because what CMS does, oftentimes the private marketplace follows. I mean, a big organization like the American Hospital Association, I mean, you have a diverse membership of some who are very interested in these issues and some who, probably aren't. But, when the money's on the table, that's when all of a sudden everyone gets interested in it. And so I think that's where, that's what we need really, I think, to get to the next level, where the business case has to be there. And when it is, then I think you're going to have a lot of progress.
And our final question from the person who's been waiting very patiently.
I'm sorry, I didn't mean to make a division between people and lunch. I'm Barb Levin, and I'm with the Delmarva Foundation's Population Health Center, and I'm going back to your question, Gloria, about who is disabled. And as a family physician for 33 years and the mother of a 35-year-old Downs young woman, I know how difficult that question is both to ask and get answered, and I'm not sure that the 6 questions that you put up there really help answer it. So we've talked a lot about provider competency and patient-centered activities. I wonder how you get around that, because clearly my daughter would tell you that she is not handicapped and doesn't need any assistance. So.
Right. I think the 6 questions really help to provide a framework and what they do and go beyond what we've had previously. So I'm just a relativist. I'm always glad for the gains we make. But I think that this set of questions helps us to start to segment that out in terms of what's the nature of the disability, what's what kinds of combinations of limitations are we experiencing. And then I do think in particular for people, if they can ask, well, do you have trouble problem solving? And if you can read the question, if you had the literacy in order to do that, and then sort of get into some of the proxy responding. I think that this will provide a beginning framework for starting to understand how we approach it. And from my perspective, makes so much more sense and goes so far beyond medical diagnoses, which is where we were before. That said, there was a reason that there are 67 federal definitions of disability, but I think we really are data-driven society. We make a lot of decisions based on that. We need to start to figure out how to cross-talk our data. So I do think that these 6 questions will come forward, and you're highlighting the very issue that a number of the communities have been raising, is it doesn't separate out IDD from mental health and disability, or from IDD and mental behavioral health. So it is a challenge.
I think the challenge stands for those of us who are in the physician population, that we somehow felt that children with special health care needs were not supposed to grow up. So I think that somehow we're going to have to come up with a institutional support for the providers to understand that they really still do get asthma.
But I do think that the care system delivery and training that's been developed for children with special health care needs can be such a great model for adults with disabilities.
Yeah. Thank you.
Thank you, and please join me in thanking our presenters again.
Well, I'd like to I'd like to remind all of you that you have evaluation forms in your folders, and if you would take time before the end of today to complete those, and feel free to give them to anyone you see wearing a little ribbon like this, or one of our folks in a TDP t-shirt. We'd appreciate that. Also, for those of you who pre-ordered lunches, those will be waiting for you. You'll go down this hallway. There's a wide staircase you can take down to the bottom of the stairs. There'll be someone to greet you there, or you can take the elevator, of course, down to the first floor. And we will reconvene here in 1 hour. Thank you.